His phone is ringing, but he's not picking up.
So when he'll contact back.
Okay, we are live, sir. Good morning to everybody and welcome to Ortho Armory Series 5. And for further proceedings, I'll hand it over to Chandak, sir. Over to you, sir.
Thank you, Ashok. Good morning to all of you. Today we are having a webinar on infection prevention in a clean case. And as we realize, bone and joint infection pose a formidable challenge to we orthopedic surgeons. And we also know that infection occurs when a significant number of virulent bacteria get into the field. And when the virulent bacteria in a sufficient number are there, we get a clinical infection. Infection is always multifactorial etiological, has host factor dependent, has environmental factor, as well as the surgeon dependent factors. It is much easier to prevent an infection rather than treating an infection. And that's why we are here. We are fortunate today we have galaxy of eminent speakers. Dr. Agashe sir, Dr. Rajiv Choudhry from Surat, Dr. Dheenadhayalan from Ganga Hospital, Dr. Rajasekaran would be joining us and we have his lecture. Dr. Tanna sir will be joining shortly. We have an expert panel in Dr. Asim Negi from Indore and Dr. Sangeet Gawhale from Mumbai. I would request all of you to be muted when the lectures are going on. We'll have a discussion after each lecture. And in the end, we'll be having a lot of queries from the delegates as well. So I request Dr. Ashok, can we start with the lecture from Dr. Rajasekaran, sir?
Yes.
I think it would be an interesting discussion on infection prevention in clean case. Welcome, Rajasekaran, sir, for you.
Is something wrong with the audio?
Yeah, I think audio is not coming, Ashok.
Okay, I'll just check again.
Because all of us know what is
Well, replay the video. Sir has sent us a recorded lecture since he had an important meeting at Delhi.
I would like to thank all of you for this honor and privilege for being with you today and talking about a very important topic of how to prevent surgical site infection. Now, this is not something new because if you see both Lister's and Igna's quotations told many centuries before, they said that 60 to 70% of infections are preventable. And that is surprisingly true even today. Now, before I talk, I want to make a disclaimer that there may not be a lot of new information in this talk because all of us know what is required to prevent infections. We have heard it before, we have read many times before, but the actual problem is not the lack of knowledge for surgeons. It's the lack of implementation. It's the lack of protocols and lack of discipline. And so when we are talking about a low rate of infections, and we are proud in Ganga Hospital in 2019, out of the 16,450 cases, when we look at a monthly denominator of how much infections we have had, it's very, very low in clean surgery. And if you have to look at how do you do it, we all know that there are so many risk factors and there are so many preventive strategies that come along with it. But I would like to talk on two important factors, which I think is going to make the clinical difference. And that is the bundle care approach that we have followed and which has got a proven value in reducing the infections, and also in effectively having a hospital infection control team and surveillance. Now, what is the bundle care approach? The bundle is a set of guidelines, which means it is not one single thing that is going to make a difference. It is a whole lot of things that are tied together, which starts from the preoperative time to the intraoperative period, and also a set of actions that you take in the postoperative period, which will create a difference in every single patient. Now, this is what we published in the spine deformity. Does bundle care approach make a difference? And we published the results of a huge number of patients, of 9,607 patients. And you find that from 2014, where we had an infection rate of 3.58% before the application of this bundle care approach, you can see that in 2018, from 14, 3.58% to 1.15% in 2019. And that's a huge difference both in the superficial and deep infections over here. And this was universal, whether it was cervical, thoracic, or lumbar spine, whether it was instrumented or non-instrumented. We were able to get a very good surgically, statistically significant difference in our infection. Now, although this was experimented and documented in spine, it is equally applicable to all other specialties also. Now, the process map of the care bundle, you can see that we took a series of precautions and actions in the pre-op, intra-op, and post-operative period. Now, in the pre-op, there are two important things. One is the glycemic control and the chlorhexidine bath, and that is taken on the previous day of surgery and on the morning of surgery. So, diabetes mellitus, we all know that that is a very important thing because it impairs the beta lymphocyte function and it reduces the body's capacity to fight Staphylococcus aureus. So you need to make sure that the HbA1c level, it's not that day's blood sugar, but we need to always check the HbA1c level that it is less than 7. And in all patients in whom that there is an elective surgery, euglycemia for at least 14 days with a HbA1c lower than 7 is very important. And when the patient gets admitted, every one of the patients get a pre-surgical kit that has all the material necessary for hand hygiene, oral hygiene, and a body shower with chlorhexidine possible. So the patients do these, and there is a nurse which is designated who will teach them how to do it and what is necessary. And all the patients have a chlorhexidine bath the previous day on admission and also on the morning of surgery. This has been very well proved that when you do this, you have a very low rate of infection. And this is something that can be easily done and that we have been following. Now, intra-op consists of clipping of the hair and avoiding shaving. And we need to do it in the operating theater. And that's very important. And all our fellows and residents are doing it. And in cases where there is no need to remove the hair, where it is not going to make any change in your incision, it is absolutely important that you don't do any of the hair treatment at all. Now, other than that, almost everything is in two important things. Maintaining a normothermia, which is very important. And second is the whole care of what is your antibiotic protocol for this. Now, I would like to spend a couple of minutes on the antibiotic prophylaxis because we all think that just giving a cefuroxime 1.5 grams before surgery is everything to it. It's actually not true because you need to give the right agent, you need to give the right time, you need to give the right dose, and you need to give it for the right duration of the time. And this is very, very important. Now, is cefuroxime the best drug that should be possible in our country? Actually, we need to doubt about it. And in our hospital, we found that in a series, as it has been shown in this paper, our maximum number of post-operative infections are gram-negative bacilli, which in case, then it doesn't matter whether you're giving cefuroxime, you probably need to give another agent which is equally effective against gram-negative bacilli. So in important cases where there is, you need to be careful whether it is cefuroxime or some other addition that you need to give for this, and we look at it very, very carefully. Secondly, it has to be a weight-based dosing, because we know that as the BMI increases, the standard dose does not work at all. This is very, very important. So when you're talking of an appropriate dosage, you need to calculate it at 30 milligrams per kg for pediatric patients, 2 grams for patients weighing 80 grams or more. So if you're giving 1.5 grams of cefuroxime for a patient who is having more than 80 kg body weight, obviously this is not enough. And if the patient is weighing more than 100 kgs, it obviously has to be much more, and so we have to be careful about it. Most importantly, this has to be given 30 minutes before incision. And there are many audits performed all around the world, even in the best of the centers, where they have found that this is very difficult to achieve consistently. So you need to be very carefully instructing the anesthetist that they have to give this 30 minutes before in the preoperative ward. Just giving them at the time of induction or after positioning of the patient takes away a huge amount of the benefits of this pre-operative antibiotics. Now that is for cefuroxime. But if you are using vancomycin or fluoroquinolones, then it's very important that this has to be given 2 hours before. There is no point in giving vancomycin on the table, because that's not going to be useful at all. And if you're using tourniquets or a joint replacement, then it's very important that you have to give it before tourniquets. And in all prolonged surgeries, it has to be given, re-given after 4 hours, or whenever there is an excessive blood loss during the procedure of more than 1.5 liters, then you need to reschedule your antibiotic concentration and antibiotic dosage and give it appropriately. So if you look at all these 4 things, and if you critically analyze, you will be surprised that in more than 75% of the times you don't give it. And so in the right way, so you need to pay great attention to this. The second important thing is maintain normothermia. Maintain normothermia, because this is something we don't concentrate on. If you have a patient who is hypothermic, and there is a lot of reasons why they become hypothermic, because we undress the patient, we prepare them, we pour cold Betadine or chlorhexidine on them, they are given repeated wound wash with cold saline, and it makes them terribly hypothermic, and this is going to be a problem in infection. So using this tight adapter for IV line, a fluid warmer to make sure that all the fluids are going inside or at body temperature, and for every single case, having a forced air warmer which goes underneath the sheets is absolutely important. All these are not high cost investments, low cost investments with a high benefit over them. So you need to pay attention to all these things. And in the post-op, again, it's very important that these patients must have supplemental oxygen for 3 to 5 liters for 1 hour. And then an IV antibiotic continue till drain removal, and then you need to give a dressing properly. Now, if you look at all that I have talked about in this care bundle, it is not high investment at all. It is just taking care of implementation of the principles that all of us know very, very clearly. So this is extremely important. And as I had shown you before, after doing this, our infection rates in 2014 of 3 and odd came dramatically low to 1.12%. So this is extremely important. Now, the second factor that we need to be really careful is about enforcement and surveillance. And here, every big unit must have a hospital infection committee. And we established in 2013 where the chairperson usually is a surgical consultant or an anesthetic consultant, but it has a whole lot of people underneath, specially trained and designated nurses who don't take any activities in nursing, but especially in making sure that the hospital infection committee rules are being followed, physician assistant and a quality cell officer. Now you can see that they have a whole lot of activities. Every Monday they have a linked nurse meeting. Every fortnightly they have an audit. They have a newsletter every 4 months. They have a HIC committee meeting 3 months. So they are quite busy, and they are looking and concentrating on different categories of staff, doing education, also surveillance, and making sure that every single thing is audited. Now this is very important. Auditing of every single activity which will be connected to infection is very important. First of all, having them is very useful because you have an accurate data every month. Now you can see we can get it at 2014, and in every year we get monthly according to whether it is clean surgery or whether it is contaminated surgery. And from every year, it is possible for you to compare with every year and every month. And then also between clean and contaminated surgery, between spine, arthroplasty, trauma, open injuries, you name it, under whatever category, you have a data in your hand. And that is the beginning point of asking why we are not doing it. And whenever there is a problem, they are continuously doing the CAPA procedures. That means action taken for prevention, and they are looking at each one of these. And they have a preoperative prophylaxis of how you give monitoring of glucose, whether the temperature has been taken care of, whether all the problems in the care bundle has been given. And you find that as we have published over here, the HIC actually looks into every single part of this. Use of the preoperative kit. Has every patient been given a kit and they have used and taken a chlorhexidine bath? Now, was the surgical clipper used in all these patients? And you can see here that the 5 moments of hand hygiene by the healthcare professionals and doctors, you can see that there was a sudden dip in the month of April, and that is a cause for red alert. And this is discussed with the whole team, and then you can see that the compliance goes up. So every part of it, every monthly they audit, and then they bring it to our notice. Just as an example, that they also look at catheter-associated urinary tract infection. Every month they have an audit and they point it to us. And they look at all these factors. Was the urinary catheter insertion justified? And has the doctor written a notes justifying why he took the decision to insert? And then they took it, is the daily assessment for the need for maintaining urinary tract. That means unnecessarily is the catheter maintained for too long. That has to be documented. The collecting bag is kept below the level of the bladder and not on the floor. Every day, somebody is looking at it, that there are no kinks in the catheter and the collecting tube. Securing device has been used to prevent movement of the catheter. Like that, in every part of it, the hospital infection committee has one designated person on each of these who are looking at it. Similarly, for the surgical site infection, they look at every one of the factors which we know for sure affects it, and then they put an audit and they bring it. So you can see that in every one of the patients, they actually look at each one of these procedures and then tick whether it has been. If not, it is marked as a red mark, and at the end of the month, this is brought to the notice of the whole team. And just this factor, regular auditing, regular surveillance, and bringing it to the notice of the treating team plays a huge role in keeping the infections low. Now, some other points I am sure that people will ask about Ganga Hospital, what they use. Do we use iodine solution irrigation? We often use, especially in cases which are important. Cases which we think that there is a high rate of infection, Then we use iodine solution irrigation because it is very well proved to reduce the infection. The second is, do we use intra-wound vancomycin? Now, this is, many studies have proved that it is very useful. But this last study, Matsubaki et al., is actually from our center, where again we did a huge study in 606 patients, and we didn't find that it was very useful. The only reason is that probably because wherever the infection rates are already low, and in hospitals where the main infection is gram negative and not gram positive, then intrawound vancomycin is not very useful. So we actually now don't use it because this is the publication that we did in spine. And in our cases, we did not find a huge use of infection. That may be because that we had our post-operative infection is mostly gram negative. What about laminar airflow? Now, that's a doubtful or very controversial issue. I think somebody is talking about it in this symposium also. The initial reports were all very highly beneficial, but recent reports many are doubtful and varied. Personal experience in our hospital, we have 36 operating theaters, 14 with laminar flow and 22 without. And personally, there has been no difference. We have studied it very often. There is no difference between in the cases where we have used laminar flow and no laminar flow. So I think a lot of other things also matter quite a lot. Similarly, we also did a quick study on whether there is a difference between using autoclavable, reusable surgical drapes or disposable surgical drapes. And again, there has been no difference in both of these over there. So it is actually in not using more costlier equipments or costlier antibiotics. It is in the surgical discipline of following the bundle care. What is important in the preoperative, what is important in the intraoperative, what is important in the postoperative, and it is actually the implementation. And in the implementation, that also has a surveillance by a very strong hospital infection committee. Every year, there will be a small upswing of infection, and when it happens, it has to be immediately found out. We have to find the weak link. Just discussion of this amongst the team brings everybody into a higher care of discipline, and we'll find that it is very useful. So again, I would like to reiterate, it's not the lack of knowledge, but it is the lack of implementation of it and the discipline that actually makes the difference in surgical site infection. Thank you very much for giving me this opportunity, and I'm glad that this topic, which is very, very important to everyone, has been chosen as the topic for discussion today. Thank you very much.
We thank Professor Rajasekaran for his excellent lecture, and welcome Tanna sir. Tanna sir has joined. After this, we'll be having a lecture of Dr. Agashe sir, and before that, we will have some discussion on the first topic itself. Can I ask Dr. Dheenadhayalan, how do you select which patient goes to which theater? Some of the theaters are laminar airflow and some of the theaters are without laminar airflow. So is it only orthoplasty and spine?
No, like laminar flow is there in mainly on the elective side. Trauma side, we don't have any laminar flow theaters. So
any policy behind this?
No, not like that. Actually, like in the beginning, when all the theaters were constructed, none of the theaters had laminar airflow.
Okay.
So, and then like when NABH was coming in, and then we wanted to have mainly the elective side as a laminar flow theaters. That's how we introduced laminar flow in those theaters. Otherwise, in the beginning, we didn't have laminar airflow theaters in any of the theaters. So.
Okay. Thank you, sir. Sangeet, would you like to operate your orthoplasty case in a regular, well-disciplined theater or a laminar airflow essentially?
We don't have choice because most of the theaters where we do orthopedic work have a laminar airflow
So
inbuilt.
you, and you would always prefer in a
Yeah,
laminar airflow.
yeah.
Thank you. Thank you.
But all the theaters have got, it is not like laminar airflow, but all of them have a airflow like a vertical airflow that coming up and then lower vent. That is the philosophy that like a HEPA filters. All those things are followed in every
Every
theaters.
theater. Tanna sir, your opinion on laminar airflow and
I think it has been shown again and again that the laminar airflow which came with the Big Bang hasn't turned out to be anything big. And the maintenance of the laminar airflow, the HEPA filter, which you have to really change it again and again. I'll give you one instance. In one of the five-star hospitals, they changed the HEPA filter. And then they wanted to do the pathological testing. So they did the culture. 2 cultures, positive, we couldn't start the theater. Now it's a big financial loss to the hospital because the main theaters are not starting. So, as we understand, third time the pathology department was ordered to give a negative report so that we could start the theater. And now all the reports suggest that as I think the laminar airflow is not necessarily something big thing.
Thank you very much, sir. And with this background, let us have the lecture. May I invite Dr. Agashe sir for his lecture on laminar airflow, current practices, the sterilization, the OT, air management. Welcome, Agashe sir. Agashe sir, are you muted?
Can you hear me now?
Yeah, we can hear you now.
Okay. Thank you very much, Sangeet, for starting this fantastic series with help of OrthoTV. And as this has been going on, this discussion about laminar airflow has been going on for quite some time. And many of you would remember this dialogue of दीवार मेरे पास गाड़ी है बैंक बैलेंस है तुम्हारे पास क्या है एंड मेरे पास लैमिनार एयर फ्लो है once upon a time the surgeons would say that मेरे पास laminar airflow है so let's discuss something more about laminar airflow. Dr. Rajasekaran, Dr. Tanna, Dr. Sangeet have already discussed a few things. Now I will just go into a bit of detail about laminar airflow. Everybody, including the administration, the surgeon, the patient, have a wish before entering the theater, and that is 0% infection rate. That obviously everybody will have that wish. About 6 decades ago, Sir John Chandley also harbored this wish, and therefore he introduced this clean air enclosure, and the infection rate dropped significantly. From average rate of about 10%, it dropped to 1%. In fact, he believed that this would negate the need for prophylactic antibiotics. Question is, has his belief turned in reality today? Where are we in 2020? So today we would discuss what is laminar airflow, what is the working of laminar airflow, how can it reduce infection rate, what are the common causes of infection, and how much importance is given to this laminar airflow, and finally, and the most important, is gyan from literature. So first and foremost, I would like to have this disclosure. When you and me always agree, one of us is unnecessary. One of us is unnecessary. That means this is a little controversial topic. Some people may have very strong opinion which is contrary to whatever I am suggesting. So what is laminar airflow? Essentially, it is an airflow moving in a single direction in parallel layers at a constant velocity from beginning to end of a straight line. So it is in a straight line in parallel layers at a constant velocity. While HEPA filters are what are called high efficiency particulate filters, and they remove at least 99.97 particles of 3.3 millimicron size. So essentially, it consists of two parts: filters to reduce the size of particle, and second is non-turbulent unidirectional flow. So what is a turbulent flow and what is a laminar flow? Before that, let me discuss this a bit. These HEPA filters are composed of a mat of fiberglass fibers, and they in fact filter larger particles larger than 0.3 mu microns, and they generally consist of three different filters: the micro pre-filter, the fabric filter cover, and HEPA filter. They need to be cleaned time and again. So what is a laminar airflow? As I said, it's a smooth flow. It's like a pack of cards moving, as against what is called a turbulent flow, which consists of eddies. There is a lateral mixing and it is rough. Now, what is the funda behind this? We all know that there are always some microbes in dust on the skin of OT personnel and lint. That means there are bound to be some microbes in our OT. As you can see here, now scales from skin of OT personnel, lint or dust, they would work as carriers, or you can call them flying saucers. And more the people in OT, there are bound to be more flying saucers or more CFUs, what are called colony forming units. And this is the way it is calculated, how many colony forming units are there. Now, all these colony forming units would be on these flying saucers. And when we operate in turbulent atmosphere, these, because of turbulence of the current, these flying saucers are likely to be deposited on our operation site, and the incidence of infection would increase. Therefore, these flying saucers pose a significant risk of contamination and infection, and that is the basic funda of laminar airflow. So if we direct these flying saucers away, then there is a chance, as you can see, they will not go over our skin, they will not go over our operation site, and the chances of infection would decrease. Now, from the filters, they could be directed either vertically or horizontally. The horizontal flow, there are so many things in the OT that these horizontal flows will have plenty of eddies, and it generally doesn't work. Most of the laminar airflow theaters have a vertical airflow because that is considered to be the most effective laminar airflow. Now, what are the downsides? What are the problems associated with laminar airflow? Now, it remains laminar if there are no eddies, and the eddies would be if there are no thermal disturbances. For example, lamps. Lamps will cause turbulence. A single lamp, there will be more turbulence, and therefore multiple small lamps are better than a larger one. Various types of models are needed, are introduced uh, in the market, and the cost is about 15 to 20 lakhs upwards. Obviously, today the hospitals are not much bothered about this 15 to 20 lakhs, but still it is a sizable expenditure. But what is important is the running expenditure. This is what I calculated at Hinduja about 5 years ago. And the cost of running a laminar airflow system, we have two different types of systems. One costs almost 6,000 rupees per day, and the other costs about 3,000 rupees per day. So the cost of running is pretty important. There are, of course, some other guidelines that you can't have fogging machine, you can't have sprays or foggers. There has to be a surface sterilization, and the walls are essentially to be made of metal sheets if you have to have a appropriate working of laminar airflow. Question is, finally what happens? Does it actually reduce? Because what are the other causes of uh, uh, infection in OT? And is the turning away of airflow very important? So when we operate, the load on bacterial load at the site is essentially because of skin. The skin microbes enter the surgical site. A patient may have various septic foci, and they would, because hematogenous seeding of the bacteria can occur, the surgical team can get in various microbes, and the most important is the autoclaving or sterilization. If it is not appropriate, there will be bacterial loading of the site. What is most important is, whenever you take an incision, some microbes are bound to enter into the surgical site. As Dr. Rajasekaran said, appropriate antibiotic at appropriate time in appropriate doses would take away most of the bugs, will kill most of the bugs. And body's defense mechanism would take away remaining bugs. And therefore, prophylactic antibiotic management of comorbidities play a very, very major role. So finally, is it all worth it? What is the gyan from literature? 2011, CORR published an article saying that both laminar airflow reduce the periprostatic joint infection significantly. Ultraviolet as well as laminar airflow reduce the infection rate significantly. However, there was a very large study by through German government actually, which was published in Annals of Surgery in 2008. And they said they studied almost 61 departments and more than 99,000 surgeries were assessed. They compared conventional AC units versus vertical laminar airflow, and there was no benefit. In fact, surprisingly, it was associated with a significantly higher risk for severe SSI after hip prosthesis. So finally, they said that this is the most important thing. 2009 again, Parvezi published an article saying that laminar airflow, a time for re-evaluation, and they said that LAF or laminar airflow does not reduce the rates for periprostatic joint infection. Another one, again, said it is not very important. In fact, they said that anesthetic screen causes disruption of normal vertical airflow. This is from WHO. Can you see the screen?
Yes, sir, we can see, sir.
I can't. Something happened. Just give me a minute.
Yes, sir.
Yeah. Yeah. WHO guidelines 2016 mentioned that LAF should not be used to reduce the risk of SSI in arthroplasty. There are various causes. They said that this actually does not work. What is more important is there may be a laminar airflow, but there are several ADs or lateral currents because of various factors. In spite of all this, Dutch working group on infection prevention strongly recommended laminar airflow. But then it was realized later that they believed or all their recommendations were based on the old data of 1982. And therefore, there was a big article by Dr. Brew saying that disregard the Dutch Health Departmental Directive. He said follow WHO, no laminar airflows. Again, 2017 Lancet Infectious Disease, where WHO as well as University of Medicine of Berlin jointly assessed, and they said laminar airflow has no benefit and should not be introduced or used in any of the theaters. Another one, 2019, 33 studies, more than 1 million operations concluded that vertical laminar airflow may be associated with increase or at least no difference in the risk of serious surgical site infection. The other specialties also, ophthalmologists also have said that there is no point in using laminar airflow, or in fact they have gone one step further, saying that even HEPA filters are not really useful. So friends, to conclude, I would strongly recommend spend time, money on OT planning and appropriate layout, appropriate cleaning and mopping, good CSSD sterilization and storage, appropriate protocol, addressing patients' comorbidities, identification and addressing focus of infection, if any, appropriate prophylactic antibiotics at appropriate time, reducing traffic in OT, carefully planning, preparing and cleaning surgical site, covering exposed hair and skin, good surgical technique. In short, strict OT discipline, train yourself, train your staff, and that is what is far more important than laminar airflow. At least for me, laminar airflow is not important. I would not like to use it. Thank you, friends.
Thank you very much, sir, for that enlightening talks. And I think Tanna sir, you and Rajasekaran sir all have de-stressed the importance of laminar airflow. There will be many questions ahead, but I think we should move ahead with the talks and take the discussions at the end so that we finish on time. So I would now like to invite Dr. Rajiv Raj Choudhry sir for his talk on sterilization methods and safety. Please unmute yourself, sir.
Yeah, we can see your screen, sir.
So on the bottom left, there is a button for unmuting, sir. Please unmute yourself from the Zoom panel.
Sir, we are not listening your voice. Rajiv, sir?
Now, yeah. Now
Yeah,
you'll hear me, yeah?
Yeah, now we'll.
So at the onset, I thank you very much for this great honor and privilege to participate in today's fifth Armory series, which is a very, very important topic. And as Dr. Rajasekaran knows, has already elaborated, everyone knows about it, but it is a strict following. And I think as surgeons, we should have certain fundamentals clear so that when it comes to seeing things and looking at our staff, we should be able to pinpoint deficiencies as the team leaders. So cleaning is the removal of the dust. Killing of vegetative organisms is decontamination, but all microorganisms being killed, including spores, is sterilization. So when we are talking of sterilization, all spores have also to be killed. Now, these are two words very interchanged very frequently, sterilization and autoclave. Now, autoclave basically is the device that is used to sterilize equipment by subjecting the instruments to a very high pressure saturated steam at 121 degrees for 15 to 20 minutes. And the amount of time would depend on the size of the load and the contents that we are sterilizing. A student of Louis Pasteur, Charles Chamberlain, devised this first autoclave, and we have gone a long way from there to the very recent models of sterilization. And we sterilize to kill all microorganisms, to prevent cross-infection, and to protect personnel and patients. This is what we had seen as children also, but this is not sterilization. And this is not the right procedure, that everything dumped at one place and then you sit down to clean it. So the process by which a medical device is freed from viable microorganisms, including spores, is what we will see. Now, sterilization or autoclaving is just a part of it. One has to limit and lower the bioburden before sterilization. And then you have to prepare adequately and appropriately. Then you have to select the correct sterilization parameters, because different equipment require different parameters, and one has to implement controls to maintain the sterility of these items till they are used. So the magic figure that we want to know is 134 degrees at which the spores die in wet heat, and we'll come to the time control in a minute. All these autoclaves or the sterilizing machines depend on the relationship or the interrelationship of pressure, temperature, and time. And if we have a pressure of 1 bar, then the water will boil at 120 degrees. And if we can increase it to 2 bars, then the water would boil at 134 degrees, giving rise to saturated steam. Now, if we are holding the equipment for 3 minutes at 134 degrees, all spores die. And if we are having a temperature of 124 degrees for 15 minutes, so that gives us the amount of time that we have to hold at a particular temperature. The methods of sterilization, either we have dry or wet heat, or we have chemical reactions with plasma, which is low temperature, or ethylene oxide. Various other methods of sterilization include vapors and liquids, dry heat, gases, radiation, but today steam, that is saturated steam, which autoclaves or sterilizes stainless steel, glass, and whatever it can handle. So we'll look at these one by one. For the vapors and liquids, they are not very commonly used because they have the equipment has to be cleaned after it has been sterilized with sterile material. Plus, if we are using any vapor form, like we used to have these plastic boxes in this manner with trays inside, the problem about the vapors and the toxicity caused was quite frequent. Now, when we talk of heat, heat kills a living organism by 2 ways: coagulation or oxidation. And the difference, so if you put an egg inside boiling water, at 52 degrees coagulation takes place, and what you get is a boiled egg. But now, if you fry an egg at a much higher temperature, the sides start blackening up, and this is called oxidation. So heat kills the organism either by coagulation or by oxidation. But the most common methods, of course, today are steam under pressure. The older methods included, and this many times in the operation theater, we used to do it. I think most of the older generation surgeons would remember that put some spirit and ignite it and have the instrument that is sterilized. And the dry heat sterilization is used mainly for glass, stainless steel, and a few other materials. The temperature that the item should be able to withstand has to be higher, and you cannot wrap it in cloth. It has to be wrapped in an aluminum foil. The most common method today is the wet sterilization, which basically is steam that goes through the hollow parts and inside various crevices of your packing material. And this is when the steam is heated, the bacteria are killed. The basic principle, so there's some water which is heated that goes in the form of a steam, and this is controlled once the pressure of 134 degrees is achieved. About 3 to 4 minutes is more than adequate. If a lower temperature of 121, 122 degrees, then 10 to 15 minutes. Now all these systems have become automatic. So the manual factor of someone trying to rush to a surgeon in the theater says, "Jaldi karo," and the person starts opening up the gasket. Those days are now virtually going to go away. Gas sterilization. So from heat we come to gas. And today the most popular one is the ETO. And that is the reason basically is the cost factor. But it is explosive and carcinogenic and requires extensive safety precautions. It penetrates best and is very, very commonly used today. Gamma irradiation or gamma sterilization is best suited for very high volumes, and usually hospitals of most sizes would not be using gamma ray irradiation. The newer techniques include flash sterilization, plasma sterilization, and ethylene dioxide. Now, flash sterilization is again a steam sterilization. There is no drying time, there is no storage time, and the process is either gravity or dynamic removal of the vacuum. Now, there are 5 steps that everyone must remember and make sure it's enforced in your theaters, so that if you are doing flash for any reason, then you are not missing the mark of sterilization. Number 1, there are no shortcuts to decontaminate. So it's not just that you wipe up an instrument and put it in flash. It has to be decontaminated meticulously. The equipment should be exposed such that all the parts of the instrument are exposed to the steam. Say, for example, there is an artery or a needle holder. One must open up the catch completely so that the steam gets direct entry into the narrow areas. Do not forget to put the indicator inside the flash, so that when the process is finished, you check the indicator that you have achieved sterilization, that the appropriate temperature has changed the color of the indicator. After confirming the flash sterilization parameter settings, one must confirm the sterilizing test, ensure proper transfer to the sterile area. So from the flash autoclave into the operating field, this carriage also should be done with gown, gloves, and it should not be taken lightly. Finally, document everything that you have done, and especially the parameters and the indicators. Now, it cannot be used in a flash, cannot be used in a package or a sterile or sterilized. It cannot be stored before you. So that's one aspect of it. And it is only to be used when there is insufficient time to sterilize an item. One must avoid using implants which have been flashed inserted into the body. it is not recommended that implants be flashed. Then we come to plasma sterilization, where we have got free ions, positive ions, negative ions, and neutral ions. And this works by 3 mechanisms. So the infrared, basically, it vaporizes the microbiological matter and it causes physical destruction of the spores. So it is a very effective way, but the disadvantages of plasma sterilization is it has very weak penetrating power. So complications can arise if there is if the packaging material is very heavy, and in complex geometries also it has a very weak penetrating powers. There are 4 types of sterilization cycles run in an autoclave: general requirement cycle, class B cycle, class N cycle, and class S cycle. We usually use the class B cycle, which is the big sterilizer, which means that all kinds of medical devices can be sterilized, including drying. So this includes drying. Now, these are a few videos that I am going to show. So one has to be very careful about the fire precautions in this area. So here we have got, it is a very well labeled situation. Now we go into my decontamination room. So if you have a look, there are 2 types of water: the plain water and the RO water, with a water gun and an air gun to clean. And now you would see that this is after the instrument is cleaned in a dryer. They are washed under pressure, and this is a separate area where the mops are also not going into the sterile area. So this is basically an unsterile area where an ultrasonic machine is being used to clean the instruments. Now there are various solutions used for disinfection. So one has to use detergent initially, but where there is organic waste of previously operated patients, enzymatic cleaners should be used very meticulously. One uses a water gun initially to sort of a jet of water is used to clean, and then especially with the hollow instruments like reamers, like cannulated drills, the air gun is used to clean the whole thing. Now I'm taking you to the linen room. Now in the linen room, you will see this is an LED light that is checking for the gowns that have got holes inside. So this gown will be discarded, this linen will be discarded. And then we go to the assembly area. Now this is all the part of the linen room. Here, one must not load everything as a jumble. It has to be done very meticulously. For the horizontal autoclaves, again, there should be space between the packaged implants, and of course, everything is double wrapped. Now we come to this. We come to the sterile room, and if you will see here, this is the area where everything is stored. This is the other part of the autoclave from where the autoclaving is taking place. And this sterile room also has microfiltered air that comes. So all the implants, instruments, all the sterile material is kept in a sterile environment. Finally, these trolleys and everything is packed on a sterile trolley. Now, at the time of autoclaving, before the first cycle, a pre-sterilization and a post-sterilization Bovie-Dick test is conducted to make sure that the autoclave is working well. A leak test is also done. There are various indicators of sterilization, biological and chemical. Now, the biological indicator, as you will see, there are 2 shown here, one below and one above, and the color changes from yellow on the left-hand side to dark blue on the other side out of the autoclave. Similarly, biological indicators are also used. Now, the very important thing is documenting it. So an autoclave register with a printout should be well maintained. Similarly, the bovedic register with a printout and a PCD file is maintained. The ETO is also maintained with a printout, and you would see that all this is documented for every single patient. Now, these are the heroes of the background. They need to be encouraged very, very frequently. Otherwise, they could be very depressed doing their work. If you don't look after them, they can start compromising, because integrity of the CSSD team is extremely vital. One small neglect, there's many a slip between the cup and the lip. And for sterilization, every single thing, every single step is important. One should not rush in. So to summarize, sterilization is killing of all microorganisms, wet heat of about 134 degrees for 2 minutes. And if it is 125 degrees or 121 degrees for 15 to 20 minutes. The most common method of sterilization is steam. Flash sterilization is recommended instruments, but not recommended for implantable devices. Ethylene dioxide and plasma sterilization are other common methods. The surgeon should keep a check of the indicators and keep the staff on guard. Remember, cleaning is very important. The best of sterilizers is not going to give you 100% result if disinfection is not done thoroughly. You need a dedicated team with integrity. I think this is a team that does not run into the theater to assist at the time of assistance, gets up in the morning at 3, runs an Bovi test, because if they are tired, then they try to cut corners. Check that all the protocols are followed, and regular maintenance of equipment is very vital. Thank you very much.
Thank you very much, sir, for elegantly presenting a very good topic and a very important aspect of theatre control, infection control measure. Any questions from the faculty members?
Can I?
Sangeet, yeah, please.
Choudhry sir, you have made a statement that if you find holes in the drape, you discard. I don't think anybody of us follows that, or any of the hospital follows that. And what
Sorry.
is
No.
It is practically impossible to discard if you find a single hole in a bed sheet or a towel or a drape. Let me complete. So the best of the hospital, if you open any drape or any sheet, you will find at least one hole in that. And in a private setup, that is also equally true. So what happens if you use a towel or a bed sheet which has a hole? Because at least we are doing a three-layer draping, 2 or 3-layer draping.
You see, this is an attempt. If there is a hole, you don't discard. Maybe you will stitch it up or you will cover it up. But if there is a hole, then a holy disaster is definitely going to take place.
Yes, sir.
Yeah, Asim.
Is it a practical experience with all the faculty? Like you open a tape and you find a hole. So, like even if the CSSD follows the protocol, still on any of the bed sheet, you'll find some holes when you open them for draping.
It does happen, Sangeet. What you say is correct. And especially if there is any workshop or something like that, we start rapidly screening those bad towels out. Routinely, they might be used. So it does happen. Yes,
Rajiv sir.
Yeah.
If you're autoclaved on, say, Monday, how long you will like to use that set? 2 days, 3 days, and same for ethylene oxide, they say 1 year. So how long you will trust that पर्ची की.
Now,
Yes,
if it has been kept in sterile area, then linen I would use within 3 days, but other equipment I am quite happy to use for 2 weeks. And every single package has got a sticker saying date of autoclave, date of expiry.
Okay.
So everything gets it. And you know what? As the leader of the team, one has to be very rigid. Despite all these things, discipline does break.
Yes.
Infection still takes place. I'm not saying I'm having a zero infection rate, but I think if we try, the problem is those of you who work in corporate sector virtually have very little control over what is happening in the CSSD. How many times would you say, okay, you have prepared a trolley for me, can I see the chemical indicator strip, whether the color was changed or not? It is, we as the leader of the team, we have to take up the onus and take the responsibility of, and it's just thoda sa bolo, sab apne aap cheez line pe aa jati.
Ethylene oxide.
Sorry?
Ethylene oxide, how long you will trust that level? They claim 1 year.
Yeah, I don't use ethylene oxide. I usually use ETO, and this is I don't mind using it for 6 months, 8 months, no problem.
So for autoclaved implant boxes, like for tibia nailing, there are holes in it, so it is not sealed. So you are comfortable to use it for 2 weeks?
Sorry, the autoclaved boxes.
Yes, like implants or say tibia nailing box.
Yeah, or even a total knee. Yeah, I don't re-autoclave.
No, he is saying it has the boxes as the holes, but you do not keep it open. It is always kept sterile in a sterile cloth. It has been bound down, or it has been, if you have the plastic, you are doing it in a plastic.
Yes, sir.
It is a double wrap.
It is a double wrap. That's not the issue.
Yeah. One rapid question. Yes, sir, please.
If I can ask you, those strips which are there, how dependable they are, and how many strips you have to put it in one autoclave?
Now, what we usually do is that big paper, the Bowie paper, is a single paper that is put inside with at least 28 layers of drape on top, 28 at the bottom. And if that color changes, that is good for me. For that chemical strip that that was shown in my slides, I would usually put 2 or 3 strips in that whole group that is going in.
And my observation was, you have put in the whole autoclave filled up, and you've done everything. And yeah. I used to put about 5-6 strips at a different level.
Yes.
And out of 6, 5 of them have become black, or whatever it is supposed to turn. And one of them has not become black. Now what do you do?
Yes. I repeat the autoclave cycle. Because there would be some areas where adequate amount of steam at adequate temperature for adequate time has not reached.
Right.
The reason is that despite the color change, because you can have false positives as well.
Okay.
So at least false negative is not allowed.
Agashe sir and then Sangeet.
Rajiv sir.
Yeah.
Yeah, Agashe sir, you wanted to comment.
Yeah. No, question. What is your protocol about dressing material? How do you sterilize it? And what is the shelf life of that?
Again, dressing material shelf life 1 week. They go in separate boxes. They're not in a drum. कि उसमें से एक वॉश पीस निकाला चिटल फोर्सेप्स से. मेरी पूरी हॉस्पिटल में चिटल फोर्सेप्स है ही नहीं. I don't have a चिटल. So basically,
does it exist anywhere?
I don't know.
Plenty of
places. I can ask the faculty.
Plenty of places, sir.
No. I'm asking, any of the decent hospitals, do they have a chittle forceps?
It is condemned to be reused again and again.
Yeah.
So,
sir, in many nursing homes, that practice still exists.
Yeah, because I think they are not aware of it. I think the chittle forceps is something which is probably has to be first discarded, I presume.
So how do you make packets? Do you make packets for dressing material or?
So these are those small tiffin boxes which we have got holes which can be closed and opened.
Correct.
And then you have got something like one package of gauze, one artery forceps, one scissor, and one katori. Now, this is packed, double packed in cloth. It is autoclaved. And once the autoclave procedure is over, I can use it in 1 week's time.
Okay. Same
Or-
practice
or
at...
the-
yeah.
Or
Yes,
the
sir.
plastic bags which are available for sterilized situations, which is easily available. Though they are a little expensive, which is transparent, you can see it and it can be sealed. They are the ones which are probably a better material to keep them and store them, because they can be relied upon.
So what is the practice at Ganga Hospital, Dheenadhayalan, sir?
No, it is all kept in small packets. It is all like in the cloth cover only we keep it.
Okay.
So they are all double layered and kept it. And then each small packets, we take it for the individual patients separately.
So to all faculty members, in case you have an instrument which has fallen down in the theater and really you are required to use it, what is your best method to reuse immediately? Is it flash or you spirit it? So whenever chance, in some time must have happened in life. So Tanna sir, have you used any chance, any occasion where you had to use an instrument which has fallen down and you
Flash.
You used flash. Sangeet?
Yeah, I think it is the only thing which can be used in a nursing home setup when I did not have a flash, or probably I was not even very aware whether I have a flash or no. We used to generally keep main instruments 2 or 3. So if one falls down, you can have the other one.
Okay.
And in a nursing home setup, it is much more easier to keep it.
Yes. Sangeet, you...
In the situations where you have only one guide wire and which has touched the OT light or your face.
Mm-hmm.
So
ignore it.
Yeah.
Cut it. Sangeet, cut it.
Okay.
Second situation, we have only one drill. We have only one drill while reaming, and that has touched somewhere else. So what we do is we cover it with bandage, we clean it with spirit, cover it with gloves or bandage, and then proceed with the procedure.
So try to avoid contamination.
Yeah.
Agashe sir, you had some real life situation like this?
Yes,
See,
several times. But of course, as both of them, Dr. Tanna and Sangeet said, some compromise occasionally has to be done, and that is generally by covering it.
Generally by covering it.
For some reason, the Hinduja hospital has taken away flash. So I'm really not, I don't know why. They said that we will not use flash anymore. So I honestly, I don't know the reason.
Okay. And then
because I'll tell you, same thing happens in Jaslok or in any of these 5-star hospitals where I work. Because they say the flash autoclave is not full. It's not a foolproof. And once it is not a foolproof, we will not allow you. So if the instrument falls down, the earliest it can come is 45 minutes to an hour.
Correct.
From the main CSSD.
Right.
Yes, Rajiv sir, you wanted to say.
At my place, any use of flash has to have a form filled. Why was the flash used? So the end of 1 year, when we see why was the flash used, would give us the way we can prevent the use of a flash.
Okay, that analysis helps you.
Yeah.
That analysis, so that you keep extra backup ready.
That's right.
Yeah. Thank you very much for that wonderful discussion. And we move on with the next lecture. May I invite Sangeet, if you want to comment by the time Tanna sir would share. And I would invite Tanna sir for sharing his thought process. If we have an infection, it is really distressing when it is our own case and we have an infection. It is much easier face saving when it is an infection at some other place and you are managing it. And if it is our own infection, how do we manage it in a clean case? May I invite Tanna sir to share his clean case? By the time, Sangeet, you can comment.
Well, I'll take about 3-4 minutes. I'll start the computer.
Yeah, sir, please, no problem. By the time, we'll have some discussion. Sangeet, please.
Yeah. We have discarded those reusable cauteries, suction cannulas, and we are using now plastic those disposable ones, or even for that matter, gowns. So many a time it happens that even though the shelf life written on that uh, pencil cautery or a disposable suction cannula, plastic cannula, or a disposable drape as of 2 years. So in the transit somewhere, like it is coming from the store to the operation theater, or it is being unused, is again being recirculated in a pack.
Yes.
It is bound to be punctured at some level. So how safe is that disposable material? Every time you cannot get, the fresh ones.
Absolutely, Sangeet, I would agree, because most of the time the hip U drape which you use, and if you try to compress the packet,
Yeah.
the air doesn't remain inside as a sealed pack. It collapses actually. So I'm always worried about this.
And a second question was about this to Dr. Choudhry, sir. Now, all this material have a shelf life of 2 years. The disposable items, even for that, like a pre-sterile nail, a pre-sterile implant has a shelf life of 2 years, 3 years.
Yes.
So, can we do something wherein our instruments which are less used can be pre-sterile and kept like that for a longer duration, so that they are not recycled or re-autoclaved every time you're operating?
Yeah, I think probably ETO is a good option. It gives you a shelf life of at least 6 to 8 months. Although the claim is 1 year, 6 to 8 months is a fair amount of time that you can keep. So I think probably ETO would be the best way forward.
And the same is true for the plasma sterilization. That also has a shelf life of a long time.
That's right. That's right. Long shelf life.
Yeah. Anyone who is using a plasma sterilizer, you are having at your place, or Dr. Deena, do you have?
We don't have. So
you don't have. Anyone who has experience of plasma?
Yeah, I have been using it in my 5-star hospitals all the time. And they keep it, they have this plasma sterilized so that it remains for a long time. And mainly some of those implants, they have been put it that way. Okay. And I think it works very well. And they have also done it, the tasting of that after say 3 months, do the culture, and it is negative.
Yeah. Thanks on that discussion, and we move on with the lecture. If an infection happens, what do we do? Asim sir, we are not able to get your voice clearly.
It's the internet. Now can you listen?
Yeah, now we can listen.
Are those newer types of indicators promoted by companies, various companies, multinationals, are they better? 3M and all those people, what Ganga Hospital uses for ensuring that it is adequately
Dr. Asim's question is, what chemical indicators and what advanced indicators to be used? Are they reliable?
They come and teach us a lot of things nowadays.
Yeah. So
this one is better.
This question will take up, Asim, in the panel discussion at the end. Let us begin with the lecture from Tanna sir. Tanna sir, welcome for your lecture.
My screen is visible, no?
Yeah, it is visible.
Yes, sir.
Okay. I'm going to talk about immediate infection after nailing, plating, or any of these orthopedic operations, even joint replacement, anything. This is the one which is neglected by many. My focus on infection occurring in first 10 days of a closed fracture operated or a closed joint replacement or anything closed operation which is done. There is no compound fracture. Such infection should not have ended in a disaster if operating surgeon was alert during those first 5 to 10 days, maximum is 12 days after surgery. My ritual in the workshops which I do, what do you do if there is a fever 4 to 5 days after the operations? And the answers which you get, and these are the true, I am talking about, this is exactly what the answers I get. Change over to higher antibiotics. See the dressing and if any pus. Probe the needle and see if any pus. All wrong. Change to higher antibiotics. Never suppress an infection in the bones after hardware. Never. It will always come back with the vengeance. See the dressing if any pus. Probe the needle and see if pus. Are you going to wait till the pus has formed? We will be too late, too late. So we are not waiting for the pus to occur. And if the pus has occurred, we already lost the battle. So the blood test. Now, this is what majority people rely on. ESR. ESR is always raised for 3 weeks post-op, whether the infection or not infection. C-reactive protein is raised for 4 days post-op and then comes down. And I have almost, this is what is theoretical, but this is not practical all the time. C-reactive is so many times it is raised for quite a few days. So it is not again, a rising C-reactive is important. It is what is being said. But then I think it takes quite a few days for it to see whether it is rising. Procalcitonin, PCT test is considered to be highly sensitive. Inflammation also gives it positive. So maybe of value, but I don't think that is any test on which we can depend upon and plan the action on that. No blood tests are useful. ESR, rising C-reactive is suggestive, not confirmative, prolactin, WBC. All these are not really decision-making in Western. They lull you to sleep. What is the warning signs? Fever after 3 to 4 days. Then the main thing to me is the pain increases, which has subsided after the initial post-operative pain. So that pain, patient will tell you, sir, I was very much so. The only thing what you ask the patient on a post-operative round 4 and 5 is, how are you? Is this pain all right? Pain increases, which has subsided after an initial post-operative pain. Increased pain, it is infection unless and until proved otherwise. Increasing pain over 6 hours is more suspicious. Fever also may be, which could be unnoticed or suppressed by analgesics. What keeps us sleeping? Our thoughts. Because fever is due to malaria, blood transfusion. It's always with chills and cycling. Fever is due to urinary infection, catheter-induced. Generally, it takes time to manifest. Pain is due to low tolerance. This is always some pain. Increasing pain is the main thing. So the question you asked on this, the pain which was there yesterday and pain which is today, is it more or it is less? And obviously, it should not be onto the very heavy painkillers. Increased pain after 3 to 4 days, this is, I feel, is the main sign. Do not sleep over this increased pain. Immediate X-ray, if the hardware is intact and still increased pain, then it is infection and nothing but an infection. Best time to do is tonight, not tomorrow morning. Do not postpone till morning. Delay will harm, never help. Next day's commitment will not let you take patient first thing in the morning. And in the and the 5-star hospitals in which I work, you cannot take an infected case first in the morning. So it will come at 5 o'clock. So that's the reason why if ever you want to do anything, commit and do it at night, 9 o'clock, 8 o'clock, 10 o'clock, whenever you find out and you feel that it needs exploration. What do you do for suspected infection? Go down earliest on the suspicion of an infection. Open up the whole wound layer by layer. Detect hematoma, pus, bead, and clean it. Send it for culture. Cut all the doubtful devitalized muscle. If any bone without soft tissue, do not fall in love with the bone. Excise it. Wash out the wound. Jet lavage. Resuture. Best chance of a normal course if opened early. 15 days is the outermost time, I think. And probably 15 days is, I think, you already missed the bus. Keep stable fixation. Make fixation stable if it is not stable. I would rather open up unnecessarily at times than be there whether to open or no. All those people who have worked with me, they know very well. Probably 2-3 times a year, I may open it up and then probably realize there is no culture positive, nothing. And then you do not feel anything bad. You tell the patient and everything is done. Start higher antibiotic immediately after the culture is taken. After the culture, results may need to change. 6 weeks of appropriate antibiotic is necessary. 3 weeks IV, 3 weeks oral. Now there is a small debate which is here onto it. But practically, this is what is I would like to do. What is prophylactic antibiotic protocol in my hospital with many surgeons? Now I ask the house surgeon. Now that house surgeon is looking after 40 orthopedic surgeons in almost all the hospitals I work. So everybody has a different protocol. So it is damn difficult for them to remember. Because when I ask them, he says, I give 1 to 1.5 days, 3 doses, nothing else. Some other people give 1 week. Third people give till the sutures are removed, 10 days. Fourth is till the patient goes home. Fifth is RMO is confused, till the time the catheter is out, till the time epidural is out. Now all these are the things which have been there. All I will say is no more than 3 doses, that is 1 to 1.5 day, antibiotic is required or it is desirable. Because anything more, you will induce the infection if it occurs. It will be kept silent, and you will end up ultimately into the big disaster. So if the infection occurs after 1.5 days, then it will be easier to really detect if the patient is not on any antibiotic. So the recommendation of the prophylactic antibiotic, appropriate antibiotic, half an hour before skin cut, before the tourniquet elevation, 24 to 48 hours antibiotics only, that is the maximum. But most of the reports suggest that 1 dose pre-operatively is the one which is most important, given in the operation theater before the half an hour before the incision starts. That is the 1 antibiotic dose. Other doses are probably just for the peace of mind or whatever is the minor evidence that this given for 24 hours is of some use. Why not more? Arguments of our OT is not ideal and ends 10 days. What happens in 10 days course? Infection is suppressed. When antibiotics stop, the bug reveal their strength again. After 10 days of antibiotic, when you stop it, the infection has occurred. The bugs are not dead. They start becoming active and the pus after a few days after reaching home. Acute symptoms do not come and hence no early warning signs. Indian practice of patients gets fever post-op and infection. How do you face it normally as a surgeon to patient? These implants have given a reaction to you. Now I am talking about when the infection occurs. How do we explain to the patient? These implants have given reaction to us. You are allergic to these implants. That is why the pain. We bombarded with higher antibiotics and suppress these symptoms. Patient is now fever-free, happy and pays us and goes home. Patient is satisfied for a while. This is how our Indian practice, if the fever comes in, is there. What we have done is, we have temporarily satisfied the patient, but created one more unhappy patient. Later, non-curable infection occurs, and in few months' time, he goes on from one cycle to other cycle to third cycle. The golden chance of win-win situation is lost. Say whatever you want to tell the patient as a business strategy, allergy, not suitable for you, etc., etc. Do it. I don't mind. But act scientifically and open up. You will win in the long term also. Do not sleep over. Best chance to turn the tide if infection occurs is first few days. What is orthopedic post-op round for 3 days? Is a social hello. 4th, 5th, and 6th day is the real round. If one has done a plate, open up the whole area which you have traveled. If one has done nailing, then clean up all open wounds, point of entry, and locking screws and incisions. Extra is from point of entry, pass fluid by jet lavage to clean the medullary cavity. If possible, pass a small tube by the side of the nail, inside the nail till it goes through, which give a good lavage. Now, even if you've done all these things, the infection may still remain, but it's so low-grade infection, as you can see here, there was an infection. We cleaned it out, washed it out and everything. Everything was then, and implant were retained. But you can see, the infection is still remain, it is lingering here, but the fracture is held up. This will end up into the healing of the fracture. If one has done prosthesis, hip, open the capsule, clean, debride and drain. Knee extra may change poly for whatever worth is the drain. Practical suggestion in India, my apology to those purists who will shake their heads. When you decide to open up on 5, 6, 7 days for suspected infection, do not tell a patient you need another operation. Second opinion will come into picture and losing golden time. Second opinion means patients wanting opinion. Wait, we see what is the hurry, get this investigation, get that investigation. And other senior surgeon will latch on to the patient and may take away. Cheat, a polite expression is hide the word operation. I wouldn't use the cheat because whenever I use this word cheat, some people feel unhappy. So I say hide the word operation. Tell a patient you need a dressing. We will keep anesthetic standby so that you do not get pain due to dressing, which is painful. It is ideally to be done in OT to avoid any further infection. Never say you need another operation. Dressing, dressing, dressing. It is a small thing. Do all legal proper documentation. Then do a dressing, a large dressing. Open up every place you had reached at the time of an operation. Never small toothbrush removal and be a peeping Tom. Patient is told we have to do a good dressing and give appropriate antibiotics for 6 weeks, which may have to be changed on culture report. If you have done this, chances are nearly 100% that the patient will have a normal good outcome without alteration due to the infection. On good outcome, patient forgets that second dressing you did. Last, at the end of the whole drama, do not charge the patient for that dressing. If you charge, he will not forget. If you don't, he will forget that dressing. Conclusion, the buck stops at you. Then only these things can be managed. Buck doesn't stop at you. Pass it on to where the buck stops. Thank you very much.
Thank you very much, sir, for bringing out that important aspect of early intervention whenever there is a spike. May I ask you the question? In case the patient does not have fever and just is feeling chills, do you still open up those patients?
See, no, I think this is a very individual decision. I feel still the pain is the major indication. The chills by itself, you may get it because of the catheter, you may get it for something else. So the chills itself, I don't think is the indication. It's increasing pain for 24 hours, max is 48 hours, increasing pain is the main criteria. Yes, Asim, you want to say something? You are muted. Asim, you are muted.
Asim,
pain and the function, whether it's a joint or a interarticular fracture, patient, I am absolutely ruthless in mobilizing them, whether it's arthroplasty or trauma. And function simply goes away. They are not able to do what he could do on day one. And the pain. More than the fever itself. Yeah.
I think I have spoken about it again and again many times. Right? Probably all of you who are faculty must have heard it at least 10 times to me.
Yes.
But this is the one which I feel every time I go out into any part of India, still they don't follow this. I don't know why. They don't follow. Yes, Rajiv? You are muted. Rajiv, you are muted.
Tanna, if on the 4th day you had to re-explore, then what is your antibiotic protocol? The same that you had given pre-operatively, or would you change?
See, I think if you are trapped in a potential infection, then I think everything comes into picture. The physician comes in, meripinin, and all those antibiotics, what you and me don't know, they are the ones you start them off till the time the culture report comes, and then probably the culture positive antibiotics comes in. Because if you had infection, you found pus inside, and still you don't know what is the culture report. So you start off. I generally have my patients generally do not have a money issue at so much. So I start with meripinin on any of those.
Penams.
Really the highest antibiotics, whatever is needed.
Sangeet, you wanted to say
temporarily.
Yeah. Sangeet.
Sir, most often in a supramajor surgery where the duration is longer, or when you are doing a joint replacement, patient is usually given a block or epidural catheter which lasts for about 3 days. And if it is very effective, patients are absolutely painless for those 3 days. And then subsequently we switch over to analgesics, not one, but at least 2 analgesics, wherein as such, the pain on 3rd day, 4th day, 5th day is very less. So how to judge actually the pain, which is a important indicator, which you said, in a situation where patient is absolutely pain-free because of the epidural block for 3 days, and then you switch over to another analgesic. Even with that, the pain is significantly less.
I would say the infection signs do not appear for 3 days. It is 4 or 5 days it appears. And then if it is infection, any of these analgesics, I'm not talking about epidurals. Epidurals will suppress everything. But any of the oral analgesics or intramuscular or intravenous analgesics you give is not going to suppress the infection pain. that pain, in spite of all those things what you give, the patient will tell you, "Sab kal tha usse aaj zyada hai." And then the next day, if it is still increasing, then that is it. I think I do not depend upon any of the investigations or anything. If, as very rightly Asim mentioned, patient is becoming uncomfortable with pain and the function which he has already started walking about, moving about, he is not comfortable. Full stop. Go ahead, needed or not needed, go ahead and open it up. That is your last chance probably in this situation.
Thank you very much, sir. Moving along, many
Asim
times.
wants to add
Yeah,
something.
my feeling is that epidural is going out of fashion for the same reason. The joints and even mega surgeries are being done under spinal or block. The effect necessarily goes away in 6 hours, or brachial block maybe 18 or 24 hours. All patients, they start walking on the day of operation by evening.
Because they are really they are also bombarded quite a lot with analgesics, and there is a local infiltration of all that cocktail which we all inject.
Right. Thank you very much, sir. One of the most difficult, challenging tasks all of us, and especially I face, is when our staff changes, how do we educate them and how do we re-emphasize them, all the methods, discipline, etc. It is really challenging in a nursing home concept. And Dr. Dheenadhayalan is now going to solve that big problem of all of us, how to educate and how to have surveillance, whether people are
I think Tanna is not working into a nursing home setup.
Yeah. So he is going to
he has a huge 400 bedded, which so large majority of us do not work in that big hospital.
Yeah. So we will have
I work in 3 4-star, 5-star hospitals and 1 4-star hospital. None of them are 400 bedded hospitals.
Yes. Absolutely true, sir. Absolutely true.
Sir, Chandak sir, don't hype so much. So it is so difficult to follow Professor Tanna and then to finally give this talk. So what I would be trying to tell you about the surveillance education is basically, I think every one of you will be doing, I suppose. So let me begin saying that if you go back to the history, like Lord Moynihan, that is more than a century ago, he observed that every operation is an experiment in bacteriology. If you look at that, if you see that even today it may hold good. So that is why I'm trying to tell you that whatever the topic that we are all discussing has been discussed often, repeatedly discussed, and still as surgeons we are trying to figure out what is the best in today's world. And we also know that the bacteria that comes in is either endogenous, exogenous, or hematogenous. But it is known that 80% of them are endogenous, and it is true. So it means patients bring in the organism. So that is why a pre-hospital optimization is extremely important. Of course, in trauma, you may not be able to do that optimization, but in all other electives, you will definitely do it. And also, we also know that the spread is by hand contact and the air quality. The air quality already has been spoken by Professor Vikas, Agashe, and also Rajiv Choudhry also has covered it on that. So let us not do it. And the hand contact is something I was thinking no one will speak on it, and I have some amount to talk about it in my lecture. So this is what is important. So if you think surgical site infection is something that you need to concentrate, it is the systems must be in place. You have to get your right system. You have to make sure that everyone in the team must be involved. It has to be a team approach. And all phases of care, like as in the first talk by Professor Rajasekaran said, in pre-op, intra-op, and post-op, in all phases of care must be extremely good, and then it must be right. And what is more important is the metrics. That is, metrics means like quantitative assessment. You need to make sure that everyone is compliant, and surveillance and continuous efforts are the most important aspect in getting this sorted out. And I'm going to talk about the surveillance and then getting it done. If you look at what is the single culprit that you would think, it is always you or me. It is the surgeons who must fall in line. Suppose if everyone fall in line, if the leader falls in line, then I think the entire team would get into a line where the philosophy of surgical site infection will come into everybody's mind and efforts. See, for example, like, this is the already Dr. Rajasekaran has put up this study. And then you see, like, in our hospital, before the implementation of all the bundles of approach care, the infection rate was hovering around 3.5. But after the compliance of everybody and then getting the systems in place and then making sure everybody is in like surveillance, that is everybody is being seen and then how it is being performed, then when we bring it all the cares approach to perfect to normalcy, then you can see that post implementation of care bundle, we have reduced the infection rate to 1.15. This is extremely important. So it means that if you are continuously monitored, you would definitely tend to do better. The success depends on the compliance of all these policies. And then everyone in the team must develop the safety culture. So everybody must develop that and then promote hand hygiene. Why hand hygiene is important? Because it has been proven beyond doubt that hand hygiene saves lives. So encourage positive behavior, and then whoever is having a negative behavior, you must suppress them and put systems in place. So if you follow all these, then we will get there. And then you need to have a committee where it does all the surveillance, preventive activities, and staff training. So let us look at this. Is an important one of the landmark paper that was published centuries ago. It was Semmelweis in 1861. See, like, there were two hospitals. This was an obstetric hospital, two hospitals. And then you see one in red is the one that is managed by the doctors, and the other one is by the maternity staff. The doctors, what they used to do was in the morning, they will go and do an autopsy and then come back to do all the labor ward. They will go to the labor ward and do the labor work. So if you see that the maternal mortality was very high in those performed by the doctors, whereas those which were performed by the maternity staffs, it was less. So what they did was they introduced all the students and doctors were required to clean their hands with chlorinated lime solution when entering the labor ward. And then because of this practice, they started this practice. And then when they found out that after that 1846, you can see that by just doing that one single intervention, they found that the maternal mortality rate fallen down. And in fact, now the doctors have started performing better than the maternity staff. So it has been proven that this is the single most important, it's a dramatic event which showed that you have to clean your hands very well. And clean your hands, it saves lives. And this one message is very important. So let us look at it. See, in our hospital, what we did was before education, that means we suddenly one day we decided we will do an audit on the hand scrub. See, you can see that consultants on average did for 4.7 minutes and sisters, that is the nurses, did for 4.3 minutes. Whereas the registrars, DNBs, fellows and anesthetists, they were doing it for very short time. So you can see that the hand scrub time itself was very, very short. You know that the scrub is done because all of them are contact antiseptics. So you need to retain the fluid in your hand for longer time so that they do act as a disinfectant. So they are all contact antiseptics. So you need to have it like that. On the contrary, when we said that we are going to supervise and then we told them about what is the steps, you have to, when we educated everybody about the steps in this hand scrub, we pasted it everywhere. And then we did the study. You can see the dramatic improvement after education. See, consultant did for longer time and everybody followed like beyond 6 minutes. See, none of them were before 6 minutes. So this is the most important. So you need to educate them, continuously monitor. And if you monitor them, it in fact changes it. Again, it's a dramatic event. So before it was, average was, if you put everybody together, it was 3.65 minutes. Now it is after the education, it was 7.68 minutes. This itself is a dramatic event. So that means if you are monitored, if there is a surveillance that is done, and if you are educated enough, then you automatically change your practice. Now you see, like compared to April 2011 that we did, in the wards also we do it. We also do the audit in all the wards. So it was like we wanted to see how many of them are compliant on this. So you can see that the percentage of complaints was very less. Now you can see the hand hygiene complaints in 2020 because we are monitoring everybody, and then it is as good as anywhere. See, like wherever there is a drop, we go in and teach everybody that, see, you have a drop in this ward, so you have to make sure that everybody follows it. And the drop may be because the new trainees have come in or new people would have been taken in the ward. So like that, there is a change that happens. So it is very important that you continuously monitor. So when you are monitoring them, automatically everybody starts to follow, the compliance levels become better. And this is one of the important things. So the compliance is better when you are monitored. So that is the most important. So we have this hand hygiene audit form, and we every day this is being monitored. Whoever walks into the patient, the nurse who goes along with that, they tick the form, and then they make sure that whether they will tell you whether you are using the hand rub or not, whether you have used a glove, in appropriate case, have you used a glove or not. Everything is monitored. So when you are done that, then automatically everyone falls into line. So that is why the surveillance is important. And also, like when you want to say that how is the outcome, you have to have a data collection. That means every data you must collect. And then every month you have to analyze, interpret it, and then you have to disseminate the information. You have to give it to everybody. You have to tell, okay, this word is like this the other word is like that. So like that, you have to keep on disinformation. That is the information you have to keep on disseminating. Then everybody will know where they stand, and then how they have to perform. So education and training becomes very important. So for breaking the barriers, you need to develop them to have a knowledge and behavioral modification, and continuous motivation is needed to change the culture. If you do this and then make sure everyone is responsible in the unit, then of course your infection control will be less. Infection control will be all right. So otherwise it is very difficult. That's why you see even the junior most, that is whoever is mopping or floor cleaning, everybody is given an opportunity to speak on hand hygiene. Everybody is given opportunity to talk about the way they are getting it sorted out. And then the staffs are continuously told about how to get the infection under control. Education materials are given. See our chairman coming in and then making sure that everything is being done, and then surveillance, he also keeps doing it. All the doctors are taught how to scrub, how to do a hand rub. All these are taught every year. That is, in the day where we have the infection control day, we have to teach all this. Then everybody actively participate. And also we do have a lot of visitors coming in. Including the visitors, we take an opportunity to teach them about hand rub, and then the scrub formalities, everything we teach. And then you see this committee meeting, that is HIC, Hospital Infection Committee. Everybody is there, and then all of them are given opportunity to speak. Where is the lacuna? And then everybody gives their opinion, and then we have to take it from there. And each member's information is taken into account, and then they are respected and they are followed. That is the way we are. Suppose if you think you are the boss and then you just want to implement everything, it may not happen. But if you take everybody's opinion, you follow everybody's instructions, and make sure if it is amenable to the control of getting the best infection control, you must follow it. And then you have to always award the people who are all doing it. Once you start awarding it, automatically there is a culture that develops where each one want to perform better. And once they want to perform better, then the entire education becomes complete. So we do conduct the quiz programs for these staffs, and also like demo classes, like how do you do the fogging, how do you do the cleaning, everything is being demonstrated to each of them. And when you demonstrate to each of them and then do it, and then overall the culture becomes like they think that it is important. So they think that they no longer take it as a work. It doesn't mean that they are working, they are cleaning, not like that. It becomes part of their habit. It becomes part of their passion to make sure that the air quality is better. The theater becomes a temple for them, so that it becomes like they always make sure that every part of it is being cleaned. And then they never take it as a work job. It is actually, they take it as a part of the patient outcome. So that is why none of them will complain that they have to do the work. After you go away, after the surgeons goes away, it is the nurses who keep doing this. Why will they do it if you are away? Because if you educate them, if you know them that it is a part of their job, and then you make them inculcate a habit that it is they who are important to get these jobs done, I think everyone in the team will do it off without any problem. They will never consider it as a major hurdle, and they will never think it is extra job for them. And also, like UV light, if they have to switch it on, they will definitely switch it on. And every day it is also monitored whether they are switching it on or not. And it is switched off 1 hour prior to surgery. All these are important. And then see, when they are doing the hand wash or hand rub, you can see that they are all taught where exactly the problems are all there, how exactly they have to scrub everything. And this is a UV hand inspection by the 3M company, and then it will let you know where all there is some sort of dirt is collecting. So it gives them the idea that how exactly they have to clean it. So these are all part of the education, so which you have to completely monitor. And then if you inculcate the habits in every team member, and of course that is the best way you can get everybody in the team, and then that is how you will prevent your surgical site infections. So of course the link nurses keep educating each one, and then we prepare them the hand hygiene champions. And then once these are all given, they continuously monitor the other nurses. So that is how it is being done. And then if you take the antibiotic policy, I think Professor Tanna has nicely mentioned it. If we always looked at the drugs used, dose given, and duration of antibiotics. There is always a compliance on drugs used and dose given on the antibiotic policy, but always there is a problem with the duration of antibiotics. So, but antibiotic policy in every hospital is set up to provide a safe, effective, and economic rational use of antibiotics, and ultimately to improve patient care, minimize the emergence of bacterial resistance in the community for the future. As a whole, we are all responsible, because in future there are not going to be many antibiotics. We have to make sure that the community for the future, we should be at large, must be responsible to use our antibiotics economically. So we have an antibiotic policy where a clean surgery means it is cefuroxime 1.5 grams single dose. Suppose if it is with implants, then the cefuroxime is continued for additional 2 doses, that is 8-hourly interval. So that is it. Whereas if it is a contaminated wound, we add amikacin that goes in. Suppose if it is contaminated wounds but come late, we have an metronidazole, but not beyond 2 days. So this is the antibiotic policy we have framed. And then you see in February 2006 that we did an antibiotic policy audit. In that, the choice of the antibiotic means that whatever the antibiotic that we have put as an antibiotic policy, 87% were compliant. Whereas the duration of the antibiotics, only 32% were compliant. Suppose if we say only 1 dose to be given means they would not give 1 dose, they would have given additional doses. So what we said was we followed it up for years and year after and year. Compliance was coming little higher and higher. But one fine day we decided that it is not going to reach 100%. So what we did was we made a new rule that consultant need permission to continue the antibiotics with valid reason. That means moment 1 dose to be a clean surgery without implant mean 1 dose means it will be stopped after 1 dose. The HIC nurse will do it off in spite of our instructions. If we have to continue, we have to take the permission from the HIC team. So when we made this rule, now the compliance rate is nearly 100%. So we have made it that it is really good. So you can see that among the consultants also, like now we wanted to see surgical site infections, because we wanted to make it like each of the consultants also need to perform better. So we said that, okay, let us have an audit on the consultants. So when we did the consultants, it is for the trauma group. So I'm happy that I am performing better in these surgical site infections. So We did that. And then our benchmark was we wanted to make sure that our infection rate must be at 1%. So we kept it at 1.5%. Then we came at less than that. So we said now it must be 1%. So you can see that nearly all of us are around that. There is no problem with that. So I think we are getting there. So this is what we said. Initially, we had a 1.5 as a benchmarking. So we are getting below that. And then you can see in 2020, there was some drop, around 30% drop in the patient load. But you can see every month we were less than 1%, except that probably in September month, in all other months, we were less than 1%. So I think we are there, we are getting there. So it is only because of the continuous efforts and monitoring. So the surveillance is the key. So if you are continuously monitored, you are always doing better. And you can also get the outcome better. And then you can see that we can also get the root cause analysis, and wherever, whatever the way, whether it could be an administration or whether it could be a consultant or whether it could be some other healthcare worker, we can find it out and you can get the remedial actions. So what is important is the analysis is important. So you can get all this process, everything can be analyzed. And overall, what we need to concentrate is these 5 patient care practices. One is the urinary catheters, vascular access lines, pulmonary functions, surgical procedures, and hand hygiene. These are the 5 things you need to definitely concentrate. And if you concentrate and give the bundles of care for each of them, like surgical site, ventilator assisted, catheter related, or intravenous lines assisted, along with pulmonary function and hand hygiene, then I think if you give all these put together, then you can definitely get it better. As far as surgical site infection is concerned, I think chlorhexidine skin prep, antibiotic 1 hour before skin incision, preoperative use of clippers, and perioperative glycemic control, and then maintaining normothermia. These forms the 5 biggest principles where you need to look at, and you always get a good outcome. But always remember that it is the implementation that is the key. If you are strict, if the leaders becomes good enough to make sure, you need to get it right, implement it, you get the resources and everything given, educate everybody together, and then overcome the resistance. There is always going to be somebody who is going to resist, but you need to overcome that. You need to put them into right place and then get it sorted out, and then audit. Always keep re-auditing, continuously re-audit. It is not just sufficient to do one audit, it has to be continuous auditing, and this will get you into a good improved outcome. And then you can always find out the cause and then get action. This is the Raj pro forma that we always do it for the surgical site infection. So we can just get it going. And then it must be a real-time check. Sudden check also you have to do, and then improve. Always wherever the compliance is not there, you have to get them, speak to them individually, and then get it sorted out. And always get a feedback. See, like you continuously ask others also what is the feedback, and if it is good enough, you have to continuously implement it. Suppose if you get a feedback and you don't implement it, they may not give you another feedback. So you have to also get that into a right direction. And always compare the performance. That's why we, like trauma consultants, in between, we also have a small competition on how to get it right and then how to get it going. So if you have that sort of competition amongst your own colleagues, then it is always easier, and then you can sort it out. So what is important is why surgical site infection we need to monitor by all multimodal activities, and the teamwork is purely because if you look, the antibiotics, there are a lot of antibiotics coming all the way up to 1970s. After that, you see there are no antibiotics coming up. There are no new antibiotics coming up. So you have to be very, very careful. Now, with the last, I think 1 year before or somewhere, I think the superbugs theory came up. There were a lot of superbugs they were thinking of. The resistance is more high. And then it is going to be a real problem. So that is why all of us, for the community service also, we must make sure you establish a good antibiotic policy, follow it so that we prevent resistance and also get your surgical site infections in better control. So you can see like 1990 was a fluoroquinolone. After that, nothing came up. So now what next? So you have to really think about it. If you really think about it, then we can get all the systems and policies in control, And of course, it will only work only when you monitor, when you do a surveillance and monitoring, and then only it will work. So in short, what I would like to say is surveillance data is the basic requirement. Data is the basic requirement for which you can do all these root analysis and remedial actions can be taken, and monitor all the process and educate everybody, continuously re-audit, get a feedback, and get the benchmark. Whatever the benchmark you set, you must achieve it, and get a lower benchmark and then try to achieve it. Then only you will get going. Thank you all for listening to this. Thank you.
Thank you very much, sir, for emphasizing on the importance of surveillance and education. Now we have the forum open for discussion. Any questions? Yes, Sangeet.
Deena, you may choose to not answer this. In your audit, one of the surgeon had an infection rate of 1.75. And in that audit, could you analyze what was the reason? Because this may help all of us because
we analyzed. So he is a pelvic surgeon. So we also found that it was a lot of the infection rate that gone up was purely because a few more pelvis got infected. So it was more like dissection time was more, the time spent was more, blood loss was more. So all these put together, his infection rate was high. So we talked to him, and then we also thinking of the way how to reduce that infection. So that was in one probably in
1 month,
2 or 3 months it was there like that. So now it was okay. So
Asim, you are muted.
For pelvic acetabular surgeries, the book recommendation is almost 3 to 5 days of antibiotics. So what do you do? I give it only 3 doses. So what should I do for pelvic acetabular surgeries?
Sir, every surgery is the same, sir.
The same. Yes. Even the books, they talk more for pelvic acetabular surgeries. I don't know why.
No, sir.
Even the recent.
If you want to see us, you have to come and see and believe us, because many of them here in India, they don't think, but you have to come and believe us. So.
No, sir. For all other patients, it's only less than 24 hours.
Even pelvis, it is the same, sir.
Yeah.
Agashe sir wanted to say. You are muted, sir.
Unmute, sir.
Yeah, I don't think there is any difference. I mean, Asim, I don't know whether this 3 to 5 days really stands in 2020. It is generally, sorry?
Agreed, sir. I use only for less than 24 hours. Most
yes,
surgeries.
Correct. Not beyond 24 hours. even in any type of surgery.
Even in compound, not in a clean case, in a compound fracture, will continue for around
2 days.
3 days.
2 days.
Till the wound is covered.
Till the wound
is covered.
Oh.
And depending on the setup, many people like Ganga Hospital may cover the wound on day 1. Am I right? In most of the cases.
Majority.
So it totally depends on when you cover the wound.
Sir, we are just speaking about clean cases. We are not discussing open injuries.
Absolutely. Yes, Sangeet.
Deena has mentioned beautifully about the education part, the training part, and monitoring. Now, I'll give a comment regarding that, related to that. And we have 3 subset of hospital where individually all of us are working. One is nursing home, second is a corporate hospital, and third is municipal or government hospital. So the importance of education, I can tell you, we did in the last setup, and I am working in all these 3 setups. Now, in a unit, usually in a government setup, we have about 10 residents, and they change every 6 months. And our infection rate is maximum in those 15 days to 3 weeks when the transit occurs. So, and we analyzed, like, they are not monitored, they are not educated about, and that is why all of them, they are making the same mistakes again and again. And I'm sure that percolates to a smaller degree in a corporate hospital and as well as a nursing home whenever this change is occurring. Your comments.
Sir, we also have seen that because usually our fellows come and go during the time of June. So if you have seen all our statistics, when we have put, it is the June time, there is a minimal peak. After that, they all come back to normalcy. Because the education time like many times we want to say that, okay, let us first 15 days, we'll just educate them. And then, but unfortunately, moment a group goes, we need to directly get the other fellows also to work. So that is why that dip comes during the June time.
And
Sir, I'm sorry. Go ahead.
I had a question to Dr. Agashe, sir. Sir, it so happened in one of the setup, the HEPA filters were not changed for 3 years. So, because the surgeon was not aware or the hospital management was not aware that they need to change that.
Every year.
So their intentions were good, but the execution part was lacking, which happens in many of the center.
I am absolutely sure, Sangeet, that in the hospitals where you are working, where I am also working, the same situation probably exists.
Yeah. So my question is, suppose like if they have a shelf or if they have to be changed every 3 months, if we do not change, does the infection rate increases?
I'm not aware of any study like this, number one. At least in our hospital, Hinduja hospital, they are changed very meticulously, very, very regularly. Our chief anesthetist makes it a point that the HEPA filters are changed. So honestly, I will not be able to answer this. But I am not aware of any study where they have plotted infection rate versus change of HEPA filter. I don't know. Are the other faculty members are aware of any study like this?
We are not aware of the study, but at least it is getting changed here routinely. So
correct.
Yeah, but you change after how long? Is there any period?
Sir,
because I have been through it in my nursing home. There is no science which is there, which is very well established. Probably the only way, what I was asked about by a friend who used to make this HEPA filter, and he gave me some of the articles. He says only way is you do the culture every 2-3 months, and probably after first 3 months you go on doing the culture every month. And if you find there is some problem of the culture on the table or anything, then only you need the HEPA filter change. Because it all depends upon how much is the usage. Like in a Ganga hospital, every operation theater is HEPA. It is used for a long, long time. While the same thing doesn't happen in the nursing home setup.
Sir, in our hospital, all the return filters and grills are cleaned. Air handling unit, motor blower, bully, everything is cleaned every month, sir. Every month, first Sunday is our day for that, sir.
That's a good protocol.
It is, sir.
Hi, Negi sir, please. Yeah, please.
How could you monitor scrubbing time of surgeons so meticulously? What was the mechanism?
So there is nothing big, sir. You just make one sister to note it.
Somebody is watching.
Yes, sir. We always make sure one nurse is watching, sir, because the table laying area is exactly opposite to that, sir. So one nurse will stand there and continuously monitor, sir.
Have you found a difference that if you really scrub for 3 minutes or 2 minutes, it makes a difference?
So that we didn't study, sir. But however, we know that all these contact antiseptics to work and then do it's better. Chlorhexidine time is little lower. They say 2 minutes is sufficient, 2 to 3 minutes is sufficient. Whereas if you are using iodine based, it has to be minimum of 5 minutes, sir.
In your setup, in the group who got infected, what was the percentage of comorbidities like diabetes? Was there any relation to comorbidities or
so
no
we checked, sir, all the infections that we have found. It is the predominant culprit was the uncontrolled diabetes. So that used to be the main reason for infections, sir.
Harjot, you have any questions on the chat box?
Yes, so there are a few questions. So the delegates want to know the preferred cleaning or washing agent by different faculties, only NS or Metrogyl or Betadine or any other.
You mean to say wound irrigations?
Wound irrigation.
Yes, the wound irrigation.
Okay. So at Ganga, what is the strategy you are using? I didn't.
Sir, in trauma practice, clean surgeries, we don't use any of the irrigations.
Right.
Any irrigation. Whereas, for example, in
Not even saline. Not even saline.
saline we use.
Huh.
See, that use. Saline we use. Saline is taken as
Okay.
no,
No, I just want to know.
No
as a
other,
rule-
no other drugs, no other drugs added to
Okay.
it.
Okay. Okay. But,
Tanna sir, what do
say-
you prefer?
Sir?
Tanna sir, what is your preference as a
No, I think
irrigation?
pure saline. I don't think any other addition of any antibiotics or iodine or anything makes any difference.
It's
So
only,
is it-
it's only the volume.
Volume of the water.
So that is regarding the clean
Now
surgeries.
whether you will irrigation with the saline or with the normal water.
So for
Normal sterile water.
Autoclaved water was
Sir,
once upon a time considered to be quite useful.
Sir, if you are discussing a clean wound, I think saline is just sufficient, sir. If you are discussing on open fractures, that becomes a different aspect.
No,
Yes.
clean wound.
So, absolutely.
And in every OT that our faculty visits, do we only follow the mopping and cleaning of surfaces, or we are still using fogging? And what agent do we use on a weekly basis or a daily basis?
I think let us have the Ganga protocol.
Sir, I think the fluid that we use is called Bacchild. Bacchild, I think. Bacchild. That is, I think, is hydrogen peroxide with silver nitrate, if I am correct.
Yes.
So, if that is being used, that is 200 ml to 800 ml is the combination, I think. 200 ml of the solution and 800 ml is the water, I think. So, that combination is used for cleaning purposes. So that is the solution. Whereas when it is on the surfaces of the monitors and things like that, it is bacillol, I think. It's called bacillol. So,
Any other question, Harjot, you have?
Yes, sir. So for cleaning instruments, do we have RO plants installed, or do you use normal tap waters?
What is RO plant? Sorry, what is RO plant?
The what?
Reverse
Reverse
osmosis.
Reverse osmosis
Reverse
water.
Drinking water.
I think that a RO plant is essential for two reasons. Because simple water, the amount of scaling that takes place damages your instruments and your autoclaving machines. So I think probably RO water is mandatory. And this RO water plant also should be routinely checked every 3 to 4 months that it is giving the proper quality, because they also tend to create problems if you don't look at it regularly. The RO stops working at times and you're not aware. I think RO plant is mandatory.
Okay.
Yes, sir. Dr. Sangeet.
So you have finished the questions, then I have to put another one.
Yes, sir. Please do ask.
We spoke about all and covered almost all the topics, but the most important is the traffic inside the OT. How do you control it? Now I'll tell you my experience. I used to shout when I was doing a joint replacement, and the sister in charge used to put outside the theater, "Do not enter." Now it so happens, and I have seen in almost all the theaters, the co-anesthetists, they enter, they go away. The sisters, the ward boys or the assistant, they come and just go away. They open the door as much time as they want. So how do you control individually? Because that is the most important factor, as I think Dr. Agashe sir has put a word or one line in that, but we have not elaborated on that. How important is that?
most of the times the opening of the door is because you are asking for something that is not available inside the theater. So you say, oh, मेरे को 4.5 का set चाहिए. And they've not kept it ready. So they go, get, open the door, come back. Or you ask for anything else, or the anesthetist asks for. So pre-operatively, if all contingencies are thought, because we went through this whole thing, you do not enter, so kuch work nahi kar. So all the possible things that you will require, if everything is in the theater, then that movement reduces. The other big problem is the anesthetist. Just can't sit in one place. So we have to tell them point blank, बैठ के तुम अपना WhatsApp देखा करो, यहाँ से move नहीं होना है, phone करना है, phone करो, but you are not going to move at all. Otherwise, next time, I'm very sorry, I will not be able to have you as my anesthetist. और सीधा उसको दादागिरी से ही बात करना पड़ता है. तब भी थोड़ा बहुत हो जाता है, but I feel probably the most common reason is that inadequate planning. And if you have gone through that before, Sara Saman, they're in closed boxes, only if required open, if not required, they go back to their sterile room.
So this air traffic is something, sorry, the theater traffic is something like difficult to monitor actually. Sometimes it is, because many times you yourself are asking for some equipment and then they will be running around and all those things, as Rajiv Choudhry has said. That is correct. But sometimes in our theaters we lock the door. Because as probably Rajiv Rai can shout on his anesthetist, but we may not be able to shout. Sometimes that is the problem. But I think what happens is we sometimes lock the door. So, but it doesn't happen with everybody. In some of the theaters, they just keep going and coming out. So there is one good study that I also, when I was preparing for this lecture, I also went through one study where they found that they were doing it for a total knee replacement. They found that the left knee replaced was slightly more infected than the right knee. And then they found out that when they went through the root cause analysis of why this has happened, I forgot the exact author name and then the article, but they said that the left knee is being closer to the door. The position was in such a way that it was closer to the door. So they found that opening the door was the reason for infection. So they closed the door and they studied. They found that the infection rate became normal. So this is also important. So that is, the traffic is extremely important to be monitored. Yes.
The other thing is that just like Dr. Dheenadhayalan said, that there is a person who is monitoring, the nurse is writing down how many minutes has every particular person scrubbed. Similarly, every time a person goes out, why has he gone out? So that would give us a real understanding. We carried it out about a year back, and the most common cause was getting instruments.
Instruments only. Yes.
So one of the delegates has asked, what are the special precautions when you take up a diabetic patient? Is it only the glycemic control? Is it double antibiotic? Or is it all same as routine patient?
Sir, when it is an elective case, like when they are coming for spine or replacement, often you will be able to get a good glycemic control. So you can do it for minimum of 14 days and you keep it as a standalone parameter and then say that you will control it and then bring the patient. Whereas in trauma, it doesn't happen. So unfortunately, when it comes, you will have to do it. And then the whole criteria is what we have put is, if the HbA1c is less than 8 or 7.5, that is reasonably good enough. And then on the day of surgery, say somebody is 300, you never take them up. You just make sure it is less than 200. Then it is okay to take them up. And then from then onwards, you have to make sure that glycemia is under control after post-op. So in trauma, it is not always possible to get it in completely under control. You can't keep any patient for 14 days or long duration, make it control and then do it. So I think you have to have some amount of leverage in these trauma cases and then do it off. And on the day of surgery, we make sure it is not beyond 200.
Now, if I can talk about it.
Yes, sir.
I have discussed with the diabetologist, which is there, and the diabetes is hardly ever an issue, they say, because the infection rate increases. Am I being heard?
So we are not hearing.
Not clearly, sir.
Because I think I'm not. Yeah, the diabetic, he says the sugar level is hardly of any importance because intraoperative, when they give the drips, the sugar level really goes on fluctuating. They give it arbitrarily, the insulin along with every drip. But so often, intraoperatively goes to 400, post-operatively it goes to 250, 400, and then it settles down. So actual the sugar, when I talk to those diabetologists, he says, you don't worry, we will control the sugar. We'll give you the sliding dose and everything what they do it. He says it is not the sugar level which is the reason why the infection occurs. It is the old diabetics, chronic diabetics who has the peripheral vascular changes. And they are the ones who get infected and not the sugar levels temporarily which goes up or goes down. It is not because almost it is impossible to keep the sugar levels in those 120, 80 or 140, 200, whatever is the level which you want to keep it. I don't know what are the views of that. I had a very long discussion with those diabetologists.
Yeah. One of the questions to Dr. Agashe sir is, Agashe sir, do you keep your prophylactic antibiotics in a clean case throughout the year same? Do you change it regularly? Or how do you judge it? What to give? So you are muted.
Last 15 years or so, we have kept either first generation or second generation cephalosporin. First generation was routinely used till it became unavailable last about 3 years or so. So we shifted to second generation, but otherwise it is same. We have not changed it at all.
Mostly you are most of the time using cefuroxime, super or whatever.
Correct.
Most of the cases.
Yes, that's it.
Rajiv sir, you wanted to give an input?
And after everybody has commented, I have a question to ask to the faculty.
Right.
Yeah. Dr. Rajasekaran mentioned that the post-operative infections in the early phase, 66% had a gram-negative bug. Our findings are also the same. So I strongly feel that just cefuroxime sodium or first or second generation or whatever is not by itself adequate to give complete prophylaxis. It is time that we should think about some gram-negative cover as a prophylaxis as well. What is the faculty to say?
So you would give one shot of amikacin or one day, or
if the creatinine level is okay, then I would go for amikacin, single shot. But if the renal function is compromised, then I may give one of the higher antibiotics that covers both positive and negative.
Okay. Sangeet, you had the closing question.
No. Dr. Agashe. Okay. Dr. Agashe sir wanted.
Okay, sir.
See, I think some of those hospitals, in those 5-star hospitals, they give you every monthly or so the report, which are the recommended prophylactic antibiotic which you should use it into this hospital, because whatever they have found out that XYZ organisms are more seen more often. So and so antibiotics is the one which they give you a recommendation. Is not mandatory, but sometimes they may almost make it that you are going to give so and so antibiotics only as a prophylactic. But obviously it is not being followed because nobody is being penalized for that. So mainly it becomes recommendatory.
So that must be depending on the culture reports, what they obtain.
Yeah. The hospital infection
committee,
the whole infection committee which is there, and they are the ones who give you that.
Yes, sir. Dina, sir.
My question to, sorry, yeah.
Sir, can I?
Yeah, please.
Sir, this is where Professor Tanna's lecture is very important, because you see, like, when we all look at an antibiotic, there has to be like prophylactic antibiotic is different, empirical antibiotic is different, and treatment antibiotic is different, therapeutic antibiotic is different. Suppose if you are thinking only as a prophylactic, 80% of the patients who are coming in are going to have only staphylococcus. So I think you have to look only an antibiotic which is more for cockeye. Whereas as Professor Rajasekaran's thing, it is infection. What comes as an infection in your hospital is from hospital-based infections. So when we looked at a hospital this thing also, when the cultures were taken in the hospitals, it was more a Klebsiella. So that's why I'm telling these rods that you get in actually are hospital based. So that's why moment somebody has got a 4th day or 5th day showing fever or somebody, that is the time you take them for deep breath and start on an antibiotic that is hospital based antibiotic. That is with the bacilli that is going to come up, or we know that empirically you can start it off with other antibiotics. So actually, prophylactically, I don't see any reason for giving other type of an antibiotics. That is my take, because I have also discussed with a lot of infection specialists also. I think we have to keep correctly. That is, prophylaxis is different. Empirical treatment, that is 4th day immediately after if somebody is throwing a fever, you have to start on those type of antibiotics. And then treatment based on what comes as a culture. So.
Yeah.
Agashe, sir.
Yeah. I'm going one step ahead of Dr. Dheenadhayalan. One should identify 5 classes of antibiotics. One is prophylactic for clean surgery before bacteria enter the body. Second is presumptive in open fractures. Though they are called prophylactic, they are actually not prophylactic because bacteria have already entered the body. So they are presumptive based on the wound. Then when there is a suspicion of infection and you have collected the material, after that you give empirical antibiotics. They need to be really strong, but they are to be used only till your culture report is available. Once culture report is available, then they are the culture guided or antibiotic guided or called targeted antibiotics. So that's a 4th class, which is generally given for about 6 weeks. And last is suppressive antibiotic, where you would consider them for a very long time when you cannot take out the implants and source control is not possible. So they are to be given for a very, very long time. So these are the 5 classes of antibiotics one should identify. So as Dr. Dina said, that even though the incidence of gram-negative infection is rising, you need not give gram-negative cover for prophylactic antibiotics, basically because prophylactic antibiotics are for most common organisms which are likely to enter at the time of your surgical incision, and they are gram positive and they are generally staphylococci, either aureus or coagulase negative.
So what is the problem of giving 1 dose of amikacin in a patient who has no renal problem?
The most ID people feel that it is not necessary and it would be harmful, as they say. Honestly, I cannot answer that, but that is what ID people say.
Well, simple logic would say that prophylaxis should be based on the anticipated organisms.
Yeah.
Now, if after opening hospital-acquired gram-negative things are coming in, I feel it is absolutely your basis of prophylaxis depends on what is your major bacterial load.
Agree.
So I would feel that giving a gram-negative in such situations is perfectly justified.
It is exactly what I mentioned, that right. we have been advised that so-and-so antibiotic, you give it prophylactically in your patients.
So apart from this,
I have a question to all.
Yeah.
What about tobacco use? Especially in clean surgery, planned surgery, would you ask the patient to stop tobacco for about a month or so and then take him up, or you would go ahead and operate?
Always we would ask them to stop, but what they tell us is, साहब बंद कर दिया, सिर्फ morning में थोड़ा लेना पड़ता है.
कौन
That's all.
सुनता है? कौन सुनता है?
So that is what they would usually come out with. Though, of course, we will always ask this topic.
Again, I think it is those chronic tobacco smokers. Is it those chronic diabetics, chronic tobacco smokers? They are the ones which are affected. Now, if you stop them for 5 days or 10 days, would it make a difference? I doubt it.
There is a good study which says if you want to say tobacco usage of any use to stop it, it must be 1 month free tobacco usage, then you can operate, and they have said that it is better. But however, like Indian study has to be done separately, sir. I think we have to compare it and see. None of us have known from Indian literature, so somebody has to do it. So.
Yeah, and if that is the situation, all my patients would land up with Dr. Tanna getting operated inside 2 days. If I say stop tobacco for 1 month, instead of having withdrawal symptoms, they will run away for this surgery elsewhere.
I wouldn't mind that.
I wouldn't mind it, sir.
So apart from the antibacterials, how do you optimize your patient? Is there any specific thing you are following? Like diet, we would say take a good nutrition diet. But are you adding vitamin C, adding B12, cyanocobalamin to optimize their healing potentials or immunity? Anything else you would do?
I think these are all theoretical questions. In this highly competitive world of orthopedics, hardly anybody can do this optimizing on the patient in a fracture case. That is out of question. And in the cold surgery also, there is a joint replacement. Also, now it has become so competitive that hardly anybody can really practice it in a day-to-day situation.
Okay. Asim, you wanted to comment on?
So what is your threshold for giving blood or packed cell to the patient? Because it has got its own implication on all other post-op things. The younger patients and the older patients.
Threshold for?
Blood transfusion.
Giving blood transfusion.
Blood transfusion.
Hemoglobin level. Yeah. Hemoglobin level.
Mine is something like below 8, I start considering below 8.
Our hospital policy is below 8, we transfer.
Below 8, I start.
Yeah, below 8. Once upon a time, almost everybody who has had a loss would be transfused. Even though the hemoglobin was 14, if he has bled, patient would be transfused. Now, generally below 8.
But do you have the observation that pre-operative, the day before the operation, the hemoglobin was 11 or 12 or even 14, as I said. And into the clean case with tourniquet without any bleeding, next day you do the hemoglobin, it turns out to be 8 or 9. And then do nothing. 5th day, 6th day, hemodilution is now looked after and hemoglobin comes back to 12 or 13, whatever it was pre-operatively. So in that phase where it is 8 and 9, and if the physician is in the picture, like in the 5-star hospitals which are there all the time, then I think the patient, nahi usko 2 blood de do, usko 1 blood de do. I feel this has been unnecessarily transfused so many times without really required.
Absolutely.
And they wouldn't even ask the primary surgeon. They would just say, they do.
They do, exactly. Now, as I said, that is true what you say. Yes. So now I ask my only XYZ physician to look after my case. And he knows it very well. 2 dictums. He will not start antibiotic post-operatively without asking me. He will not give blood without asking me. And he will not make the patient unfit without asking me.
And he will not start Clexane injections.
Yes, that's true. That's true. Absolutely true. Absolutely true.
So now, Sangeet, you were asking the last question, which was possibly would be the closing question.
No. I finished.
There is a question for Tanna sir for early detection and treatment part.
Yeah.
So sometimes we operate patients who have a puncture wound, like grade 1A fractures, like we have done a tibia nailing, and after 2 or 3 days, there is some discharge from the open fracture side. So should we only debride that area, or we have to take him under a spinal and do a...
It is not infection. probably you have not done the debridement on day one on that small puncture fracture which is there, puncture wound which is there, which you should do it. So in this is a very special situation which you're talking about. There probably you need nothing to be done. Even if there is a small oozing occurring from that site, you don't need anything to be done unless the pain is increased or the fever is set in.
Okay, so thank you, sir.
Thank
So
you.
there is an interesting question for Dheenadhayalan, sir. So if a resident or fellow or a nurse needs to use a washroom in between, so your washroom is outside OT complex, or whether the person will have to come and change back the scrubs?
No, OT complex will have a washroom. Why it won't be outside? So each of the theater will have a washroom, but it will be like semi-sterile area. There will be a washroom. They can go and come back.
Okay.
Okay.
So with the ending of this webinar coming up, a rapid fire, 3 important things take home from Agashe sir, Tanna sir, to begin with you. 3 important things you would emphasize for a clean case to avoid infection.
First and foremost is the dissection. I feel I'm fully convinced the ophthalmologists, they do the cataracts and so many other people do the surgeries into the far off places, into the make-believe theater. So I think it is that they are the very good surgeons. So same thing into those clean surgeons, the infection rate is comparatively very, very insignificant. But if you are messing around in the exposure and if you are really enduring the injuries to the muscles and all, then only the infection rate increases. All other factors, I feel, are subsidiary. They are important, no doubt. We got to look after all of them. But if you get everything, but you are a messy surgeon, your infection rate will always be high.
So emphasis on a clean dissection. Agashe sir, your take home point?
Yeah, don't invest money in laminar airflow.
Don't invest in laminar airflow. Give it to me.
Yes, at least 10% give it to me.
So clean dissection and all rest of the things very important. Rajiv sir, your take home?
I think the onus of infection should be with the surgeon. He should be taking up the responsibility, but making sure that all the systems are working and all the staff that is involved is incentivized and encouraged to be the part of the infection control team.
Okay, thank you very much. Dr. Dheenadhayalan sir, your take home?
I think everybody has said everything. So, but I think all the care like pre-hospital, during and post, everything has to be taken care of for sure. But I think it is always wonderful to have all your colleagues in your working along with you and then taking care with you and then following all the principles laid out. I think that will be the wonderful team that you can ever have.
Yeah. Thank you very much. Asim, your take home on infection control in a clean case. How do you manage if you see a patient who has an infection and how do you convince?
I'm out and out DDT's trained boy, so I use all the tricks and I'm absolutely ruthless.
Yeah.
They are all doing, you must be seeing all those photographs. I'm extremely aggressive in mobilizing all those fracture patients, orthoplasty patients, and if patient's function is not good at day 4 or 5,
you'll
use
go
all the tricks. Yeah. And it's, for 30 years, it's only 1 day of antibiotic.
Thank you very much. Sangeet?
But amikacin is there. Amikacin is there. I use amikacin
single shot. So you use amikacin along with gram-positive?
Along with a gram-positive.
So that
it keeps on changing. It used to be cefuroxime. Nowadays, it's something else.
So every 3-4 months, you keep on changing them?
No. It all depends on what laboratories and those people suggest. Yeah. It goes
I change the antibiotic depending upon the assistant who changes.
So whatever he writes.
Sangeet,
Sangeet, how would you sum up the whole webinar?
Yeah, the most important is reducing the wound exposure time, and that can happen only if you have planned what you are going to do and you execute as per your plan.
So good planning.
Yeah. Reduce the exposure time as less as possible of the wound. That will reduce your infection rate significantly. And second is about the discipline. And the last thing is still in most of the nursing homes, the back is still open. They don't have a back cover even to cover the back, which is where the back is touching everywhere on the trolleys, on the OT drapes and everywhere. So the discipline part is lacking in most of smaller theaters.
Which,
Yeah,
which,
Chandak
which,
sir, Chandak sir, yeah.
Sangeet, which nursing home you worked?
The earlier one, except yours.
Salah bolta hai,
Sir,
you are saying almost as if you are telling my nursing home you talking
No,
about.
back apron used to be there in 87 also, sir.
No,
Chandak sir.
no,
Yeah.
that has been
The-
replaced
the-
by a
the-
flap. That
Yeah,
has been
yes,
replaced
yes.
by a flap, and most often it is not covered adequately.
Yeah.
Right. Absolutely well said.
Chandak sir.
Yeah, please go ahead.
The gowns mostly they are recycled linen gowns, and you can have a waterproof covering, but if it's not there, then they get ready-made ones. Hardly 50 rupees it costs, but you can put a disposable one, which comes pre-sterile. So
So I
first
think-
layer is that waterproof thing and pre-sterile, gamma radiated, and then the linen apron can go.
Yeah. So on that note, with all the tips from our faculty members of proper sterilization, proper precaution, proper dissection, and we get really enthused whenever we see somebody taking still more precaution. We go on improving our armamentarium to give our patient the best whatever we can offer, and this learning continues. Thank you, Ashok. Thank you for providing this platform. Thank you all the faculty members.
Thank you,
I
sir.
think this webinar would come to an end. Ashok, if you are there with us, we would like to thank you for providing this platform. It is really doing a wonderful service, and all of us can enjoy the talks later on whenever we wish to. Thank you so much, all the faculty members. We would close this webinar with Vikas. Agashe sir, you wanted to say something? Or, yeah, you're muted, sir, please.
I hope that we are able to meet physically in next few months.
6 months.
Yes.
Next Vairog.
Yeah, let us
Next
hope we
Tromacon.
would let us hope for
Viroc and Tromacon. Yes.
Thank you
Okay.
very much. And thank you, Tanna sir, for
Thank you, sir.
conceptualizing this Armory series on infection in a clean case. Actually, the idea was given by Tanna sir. Thank you very much, sir.
Thank you very much. Bye-bye. Bye-bye.
Bye, sir. Thank you.
Thank you, sir.
Ashok, you are there with us? I'll call Ashok so that we can close this meeting. Sangeet, on your question of closing the door, etc.,
Sir,
how do you manage all those things?
sir, I was an enemy to everybody at a time.
Yes, it does happen. It
I
really.
used to shout on everybody
Yeah.
because they used to open unnecessarily. And, like at a point it was, अरे वो theater में बिल्कुल मत जाना, संगीत operate कर रहा है वहाँ पे.
Yeah.
It
You
used
have
to
be
happen
ruthless.
that way.
Yeah.
That was the only way I could control them.
Yeah, we have to be really ruthless
Yeah.
on all those disciplines.
Yes.
Still finding it difficult in this world where the juniors, the ward boys have learned the habit of not following orders. They
Sir,
are on WhatsApp.
You have a control of your own nursing home. But for us, where in a corporate hospital, where every 8 hours the nurses are changing, the ward boys are changing, they are coming to get instruments which are placed in that theater, it is really difficult to control them.
Yes.
And they find some reason to go out because they cannot sit at one place or stand at one place for more than one hour at least. So they keep on opening for some pretext. They go out. ये नहीं है, ये suture material नहीं है, उसके लिए लेने के लिए जाने का है. But it's difficult to control them.
I think whatever Dheenadhayalan sir has said, I am going to form some committees, secretly observing persons and giving a report monthly card. That would be a good option actually.
And one thing which is puzzling me, like we cannot operate in a theater which is about more than 20 degrees. Okay. And for reducing the infection, you need to control the patient's body temperature.
Yes.
That is what Rajasekaran has said.
Yes.
So that warmer really helps because outside temperature is 20 and you need a higher temperature to control the body.
Yes.
So how does this balances?
So what Sir, please.
It really definitely works, Sangeet. If you see the
Sir,
warmer,
I'm not doubting, but the temperature difference, how does it, yeah. So outside it is say 20 degrees and like a warmer can reduce that from 20 degrees to maybe 2-3 degrees.
No, 30 degrees.
No. It really goes up. If you really, you touch the patient, you will realize it. Those who are on the warmer, you'll realize it.
So, Sangeet, we have three strategies for that. So there is one under blanket, which is the best in the world. They are from Germany, so that there is no electrocution, etc. problem. And then there is a overhead long warm up on both the arms, and then this is bear hugger. So all these three things combined keeps the patient quite warm. Otherwise, shivering patient is really a difficult thing to manage unnecessarily.
Because that means the patient has to be covered adequately to maintain that temperature.
Yes, absolutely. He has to be covered. In one of the theaters here, they are using silver foils to avoid the heat loss. I don't know whether that is.
But has it happened to some you, Sangeet, or no? I think we are working in the same hospital. That not the patient, but at times the surgeon needs the warmer. The damn thing is so cold at 16 degrees and 17 degrees.
We use double gowns in that.
Yeah.
Thank you, Ashok. Thank you for providing this platform. It was really, we enjoyed the webinar. There are a lot of take-home points as well.
Thank you so
much.
Thank you very much, sir.
Bye-bye.
Thank you, everyone. Thanks a lot. Thank you, Harjot. That was wonderful backup.